one and all gathered here on account of the 7th National Conference on Innovative Practices in Clinical Training and Patient Safety, organized by the Indian Pharmaceutical Association, Dakshina Kannada District, Local Branch, Bangalore, in association with Srinivas College of Pharmacy, VALACHIL, Bangalore. Before we begin with the scientific session, we ask you to please turn off your cell phones and electronic devices or put them on silent mode during the presentations to minimize their distractions. We encourage the audience to engage after the presentation and maintain the decorum activity. Session 1. It is my utmost honor to invite Dr. Chandrasekhar B.M., Professor and HOD of Pharmacology and Toxicology, HSKCP, Bangalore Chairman, BOS, PharmD, RGOHS, and Dr. Nilesh K. Chandar, Head of Department and Professor, SC Srinivas College of Pharmacy, to chair this session. I would also like to formally invite Dr. Radhika Shanoy, Professor and Head of Department of Biochemistry, Srinivas Institute of Medical Science and Research Center, Mukka, Bangalore, onto the dais. Now I request Dr. Karunakar Hegde, Professor, Srinivas College of Pharmacy, to welcome Dr. Chandrasekhar B.M. with a bouquet of flowers. Thank you, sir. I request Mr. Gopi Krishnan, Associate Professor of Srinivas College of Pharmacy, to welcome Dr. Radhika Shanoy with a bouquet of flowers. Thank you, sir. I also request Mrs. Sindhura D., Associate Professor of Srinivas College of Pharmacy, to welcome Dr. Nilesh K. Chandar with a bouquet of flowers. Thank you, ma'am. May I now request Dr. Chandrasekhar B.M., Professor and HOD of Pharmacology and Toxicology, HSKCP, Bangalore, Chairman, BOS, PharmD, RGOHS, to introduce the speaker. Dr. Radhika Shanoy, Professor and Head of Department of Biochemistry, Srinivas Institute of Medical Science and Research Center, Mukka, Bangalore, to the gathering.
Good morning to all. Good morning to all.
Good morning, sir.
So it is a very pleasure to introduce today's speaker, Dr. Radhika Shanoy. Presently, Madam is working as a professor and head in Srinivas Institute of Medical Sciences and Research Center, Bangalore. Madam has a 16 years of teaching experience. Currently a professor and head in Department of Biochemistry at Srinivas Institute of Medical Sciences, Bangalore. Pursuing MBBS from KS Medical Academy, Bangalore, and MD from AJ Institute of Medical Sciences, Bangalore. Madam has published various research articles in national and international medical journals. Madam is a member of Medical Education Unit and also a member of Board of Studies of Srinivas Institute University. Madam has undergone training in ISO certification 2022 for various medical laboratories. With this brief introduction, Madam is going to deliver a talk on advancement in genetic testing for early diagnosis of inherited disorders. With this briefly, I request you, Madam, please kindly deliver your talk.
morning everyone. So genetics is a wide topic, okay? And the recent advancements what are happening is a huge topic. So I have tried to concise it as much as possible so that it is very easy for you to understand what I am talking right now. Because we can go into a area which is not at all comprehensive by us. So it can go to that extent, the recent advancements. And AI in genetics, artificial intelligence, what is happening in genetics right now is under study. So that itself is a very wide topic. So I will just touch and go through all the recent advancements which have happened in genetic testing for inherited disorders. So according to the National Human Genome Research Institute, genetic disorders, they are arising or resulting as a deviation from the usual sequence of DNA, either whole or partially. Okay, there should be some fault with the gene sequence. Either the whole gene sequence may be present or absent, or there may be a duplication, or there may be deletion, or there may be transversions. Either the part of the gene sequence or the whole gene sequence may be affected. Now, what causes these changes in the gene sequence is nothing but mutations. So the mutation that can happen either can happen in a single gene that comprises the monogenic disorders. Multiple genes, that is the multifactorial inheritance disorder. Or there can be structural and functional alterations in the chromosomes. It can occur at the level of the entire chromosome. So this mainly is because of the damage to the chromosomes which is happening. Now why is this damage taking place? Damages can happen to these chromosomes or at the genetic level, mainly during replication. Okay? Replication. Then there may be any exposure to mutagens. So there is n number of mutagens around us. Okay, the X-rays, the gamma rays. So there are a lot of mutagens. There may be chemicals which can affect. So all these can contribute to the change in the genetic structure. Or it can be inherited from the parents to the progenies. Either can be autosomal, X-linked, recessive or dominant in nature. So how do these mutations manifest? They will manifest as single nucleotide variations. Either there may be change in one nucleotide, which we often refer to as the point mutations. There may be insertions, that is, a different sequence may be introduced into the gene. Or there may be deletion. A particular sequence may disappear altogether. Or there may be entire rearrangements. A part of the chromosome from one chromosome can entirely rearrange, go to some other chromosome and attach itself there. So these are the various variations which can take place. Now, how do we get to know what are the different causes of the genetic disorders? So what do? We do genetic testing. Okay? There are different types of genetic testings. Diagnostic testing. Now what do I mean by diagnostic testing? I know that a patient is having a particular genetic disorder. Now how do I know? Because he's having some clinical features or he's having some presentation, he's presenting with the clinical features of characteristic features of some genetic disorder. I want to confirm my diagnosis that he's having that genetic disorder, so I will do diagnostic genetic testing. Now under this diagnostic genetic testing, you can go for molecular techniques or you can go for chromosomal analysis. Okay, that is karyotyping. Then there is predictive testing. Now what do I mean by predictive testing? When I know that he's having some symptoms of a genetic disorder, but I don't know what it is. He may be having multiple features which are not characteristic. Some few low IQ or maybe some clinical features which is not exactly indicative of a particular genetic disorder. It may indicate to 3-4 different types of genetic disorder, and I want to know what exactly is the disorder in him I will do a predictive testing. That is, either I do a targeted gene testing, that means I am targeting a particular sequence of the gene which can be tested, or I will do an entire gene panel, that is, I do test for many genetic disorders so that some at least come positive and I know where the problem lies. Carrier testing. Suppose the parents are carriers or they are having a genetic disorder. One of the sibling has a genetic disorder. I want to know if the other sibling also has a disorder or is a carrier of a particular disorder. Then I will do the carrier genetic testing. Prenatal, before birth. Okay. Suspected children, when you have an X-rays or the ultrasound which is giving you some indication that the fetus which is there in utero may be having a genetic disorder. So what can you do is you can do amniocentesis or chorionic villus sampling and do a testing or karyotyping in these children. Pre-implantation genetic testing. This is at the level of the embryo before the implantation takes place. This you can do the whole genome sequencing, or as of now what we call the latest development, that is the next generation sequencing in these conditions. Now what do I mean by whole exome sequencing? There is a terminology, whole genome sequencing, whole exome sequencing. Whole genome, when I say a whole genome, the entire gene is sequenced. When I say a whole exome, it is the entire exon. Okay, I am sure all of you know what is an exon. So the entire exon is sequenced. So the entire bulk of an individual's DNA is sequenced to find the genetic variation. So it is useful when a single gene analysis or a panel testing, that is a panel genetic analysis, is not giving you a diagnosis. You are suspecting some disorder in an individual and a single gene is not going to give you a test. It is coming as negative or the sequence is coming normal. What can you do? You can analyze or do the genetic testing of a whole exome. Cost and time effective than performing multiple single gene or panel test. So you take one single gene and analyze it. It is going to take you a lot of time and lot of cost. It is going to be very, very expensive. Instead of that, take the whole exome and then fragment it and analyze it. It is going to work out much better cost-wise as well as time-wise. Next are chromosomal tests. Now what do we do in chromosomal tests? As the name suggests, we are going to analyze the chromosomes. So the long lengths of the chromosomes are analyzed to identify significant alterations. That is, either there may be extra copy of the chromosomes, that is called as trisomy, or there may be loss of a chromosome, that is monosomy. Okay? Large chromosomal segment duplications can happen or deletions can happen, and there may be segment rearrangements, that is called as translocations. So here, when do we employ chromosomal tests is when the genetic conditions are linked to chromosomal changes. For example, in case of Williams disease, the defect lies in the microdeletion. There is a deletion in chromosome 7. So in such conditions, when you know where the defect is and the patient is presenting with the clinical features, then you can go for direct chromosomal analysis. Gene expression studies. Now what do I mean by gene expression? What is a gene? Why do you need a gene? Gene is actually what is a function of a gene. There is expression of a gene taking place. When the gene is expressed, what is produced? There is mRNA which is produced. This mRNA either synthesizes a protein or an enzyme. So how do we know whether a particular gene is expressed or not? First of all, when the gene is activated, there will be mRNA which will synthesize an enzyme. If the enzyme is absent in an individual, then most probably the likely cause will be the gene inactivation which has happened, because of which the particular enzyme is not produced. So for this we do the gene expression studies and we try to know whether the mRNA is present or not for that particular gene. So overexpression or underexpression of these genes will be known. For this we do the biochemical tests. We do assays for particular enzyme, mainly done in case of inherited disorders of inborn errors of metabolic pathways. Various metabolic pathways in biochemistry, they have got enzymes, and most commonly when the enzymes are absent, it is mainly because of the inactivation of the gene. So now, mutations what can occur? There can be gross mutations which are taking place, or there may be minor alterations. So gross mutations, there are whole and large scale deletions which can take place. That means the whole gene may be deleted, there may be duplication, or there may be rearrangement. For this, what are the various tests which we can do? First one is the fluorescent in situ hybridization, which we refer to as the FISH. Okay. Next is chromosomal microarrays, that is CMA. These are all abbreviated, known abbreviations for these techniques, and then there is cytogenetic karyotyping or analysis. So these are the ones which are done for gross mutations. There may be minor alterations which are taking place also. So these are the single base substitutions, what we refer to as the point mutations, insertions and deletion. That is a single nucleotide or a sequence may be inserted or deleted. For this we have the single strand conformation polymorphism, and the right now what we have at present the latest advancement, that is the next generation sequencing. Now what specimen do we collect for analyzing these? For FISH, that is fluorescent in situ hybridization, there is a technique called as MLPA, that is multiple ligated probe analysis, DHPLC, that is denaturing high performance liquid chromatography, and for sequencing. Okay, that is the next generation sequencing. We use the peripheral blood only of the individual. For non-invasive prenatal testing, that is in case of any suspected Down syndrome, trisomy 18, trisomy 21, etc. Then we can use the amniotic fluid cells and the cell-free fetal DNA. Now what anticoagulant do we use? We most commonly use EDTA, that is ethylene diamide tetraacid acid. If we want the cell features preserved, okay, the cellular form and whatever the subcellular organelles and the functions, if they have to be preserved, then we should use the preservative acid citrate dextrose and collect in these tubes so that the features of the cell are preserved. So first is the fluorescent in situ hybridization, which I told you is referred to as the FISH. So what do we do here exactly? We are using fluorescent probes. Okay? There are probes, that's a small segment of DNA to which a fluorescent dye is attached. Most commonly we use fluorescein or rhodamine dye to tag them. Then we have these probes are complementary to the DNA sequences to which you want to probe to hybridize. Okay? And most commonly the cells should be in the metaphase. When you are going to do this technique, the cell should be in metaphase, and this why? Because it gives you a clear visualization. If the cells are in metaphase, the visualization will be more clear. And after that, we use the housekeeping genes as probes for control. We need a control. We need to compare it with something. Okay, so that control is by the housekeeping genes. Now, you cannot use a very short or a small probe. The probe must be large enough what you are using. That I told you, it's a small sequence of DNA. And it should not interfere with the hybridization process of the cell. Next is this particular technique. For this, you can use any type of cell. You can use a frozen, you can use cultured cells, you can use suspended cells, you can embedded tissue cells. You can use any type of cell. Okay, not just, you need not use only, usually what they do is they use cultured cells. But for this technique you can use any type of cell, and when you hybridize the probe, you get a signal. That means whenever that particular probe is going to go and become fixed or hybridize with the complementary sequence, that dye which is attached or tagged to the probe will fluoresce. If you watch under the fluorescent microscope, it will give you a signal, a fluorescent signal. That means it is hybridized and a particular sequence is present. Next. Now, what are the indications for doing fluorescent in situ hybridization? So, this prevents unintended hybridization. Why? Because your probes are specific to the sequence to where you want it to hybridize. It will not go and bind to any of the sequence in the DNA. It will go and bind only to that particular sequence which is complementary to the probe. Next, for patients with family history of deletions, known deletions, suppose the parents have a chromosomal deletion, okay, it's known that they are having it, and to detect any deletions in a single blastomeres during pre-implantation. In such conditions, this is very useful. Again, the example what we give here is for Williams syndrome, where there is a microdeletion in chromosome 7. Also used for prenatal testing, trisomy 13, trisomy 18 and trisomy 21. For Patau syndrome, Edwards syndrome and Down syndrome, this is very useful. So this technique, it uses gene-specific probes, okay, to investigate deletions, amplifications and translocations in hematologic and solid tumors also. So suppose a person is having any tumor, in such condition also this fish proves to be of use. Mainly in the case of Philadelphia chromosome, where there is a translocation between the PCR gene on chromosome 22 and APL gene on chromosome 9. Then we can use it for cancers, to detect cancers. The BRCA1 gene in case of breast cancer, which is one of the risk factors for breast cancer, on chromosome 17q21, this particular technique is useful for its diagnosis. So this is what I was talking about, the Philadelphia chromosome, where you have the ABL gene on chromosome 9 and on chromosome 22 the BCR gene, which is translocated. Now what is translocation is the entire segment of a portion of the chromosome is rearranged between the two, that is 9 and 22, the entire segment shifts. So it is called as a balanced translocation. Okay? There is no increase or decrease in the number of genes or chromosomes. It's just that one segment from 9 goes and attaches to 22, another segment from 22 comes and binds to 9. So it is a balanced translocation. So this is how the picture is seen in case of fish analysis. So here you have chromosome 22, which is fluorescing red, and here you have chromosome 9. These are the control, what you can see. But this is the Philadelphia. I don't know if it is obvious from there, but you can see that it is a mixture of both the colors, which is seen in the Philadelphia chromosome. Both the red and the green fluorescence can be seen here. So it is how the picture appears in case of fluorescent in situ hybridization. So this can also identify intracellular microorganisms and parasites, like in case of Chlamydia trachomatis and Mycobacterium tuberculosis, where you are using probes against the fluorescent tag probes against the RNA of these particular microorganisms. So you can see they bind to their genetic material of the microorganisms and they fluoresce. So this is in case of Mycobacterium tuberculosis, what you can see. Then there is fluorescence in situ RNA hybridization. This is the latest what they are doing right now, is when they are going to use the mRNA, localize the mRNA expression, okay, of the specific genes in tissues. So usually in fish we use DNA, but it has been now extended up to the mRNA also, which can be done with this technique. Now what are the limitations? Every technique has got limitations. Not that any technique is perfect. It has got some limitations. There may be some drawbacks which can take place. So diagnosing common fetal aneuploidies, it has a reduced sensitivity. Now what do I mean by this? When I say fetal aneuploidies, trisomy 13, 18, 21, that is the Patau, Edward and the Down syndrome. If you don't know which one is the child having, then it becomes very difficult. If you know exactly that the child is having a Down syndrome, to identify or confirm the diagnosis, you can do it. But again, compared to cytogenetic analysis, means karyotyping is far better in diagnosing aneuploidy than using fish for it. Okay? The fluorescent in situ hybridization gives you a very reduced sensitivity. If you don't know what aneuploidy it is having, maybe it can be a Williams syndrome, or you don't know. So if you suspect any random genetic disorder, it becomes difficult to pinpoint what exactly it is, because you're just getting a fluorescent pattern. You are not getting a quantifiable result of a particular gene. Okay, it is just that the sequence, whatever the probe is having a sequence, it is going to hybridize to that and fluoresce. You are not getting a value in a number saying that this particular gene is defective. That is why it becomes difficult. Cannot identify beyond cytogenic abnormalities beyond translocations, inversions. So if there is a translocation or an inversion, or if there are any markers, it can identify. But in case of duplications, deletions, this is not very effective. It is time consuming. So it takes a lot of time because you have lot of preparatory steps. Then you have to wash the probes, you have to hybridize the probes, you have to wash the probes, then you have to visualize it under a fluorescent microscope. So it is time consuming, and again it is not very cost effective because you need a good setup of a fluorescent microscope. You require extensive laboratory preparatory rooms which are needed for each step to be done, and it has got a limited throughput. That means you cannot do multiple samples at the same time. If you are getting one sample from one patient, you have to run that and then go for other samples. You cannot run multiple samples at the same time. And resolution. The resolution is not very good. If you have seen the picture, the resolution of it is not very good. It has got limited resolution. And unless you wash the probes cleanly after they hybridize, if it is not done, then autofluorescence may be seen. That means from the background, when you are visualizing, there may be fluorescence seen in the background. So you will not be able to, unless you are an expert in that field, you will not be able to identify exactly where the fluorescence is. Whether it is in the chromosome which is happening, or whether it is somewhere outside, whether the fluorescence is from the background. High specificity. Okay, this is sensitivity is low, but if you know which disorder or which syndrome you are targeting, the specificity is wonderful. High specificity you get. Alright? No need for cultured cells. I told you, you can use any suspended cells, the formalin fixed cells, etc. Visualization of the chromosomal structure. You will not get a quantifiable result, but you can visualize the chromosome clearly. And simultaneous detection of multiple targets. Because you can use multiple probes at different sequences, you can have multiple targets simultaneously being done in one shot. Okay? Next we have the chromosomal microarray, which is called as CMA. Now this is again a high resolution technique used to detect chromosomal imbalances which are not visible through traditional karyotyping. When I say this, it means that it can detect submicroscopic genetic changes. Now what do I mean by submicroscopic genetic changes? From this we understand that we can identify copy number variations. Now what is a copy number variation? Whenever there is, see, you have a fixed number of chromosomes. Okay? Whenever there is a duplication, there will be an increase in the segment. Whenever there is a deletion, there will be a decrease in the segment. Okay? That is the copy number variation. number of copies which are there of a particular sequence is fixed in an individual. If there is increase or decrease, that is a duplication or a deletion. Next. So this is how a microarray appears. That is a chromosomal microarray. This is a plate. Okay, polystyrene plate with wells into the plate. Each well will have a probe. Okay, they will have a probe attached to a particular sequence. Different probes are put in different wells. Then you take a patient sample for which you label it as green. You tag it with the green dye and you take a reference. You need a reference because you need to compare that segment what you are deriving from the patient to a standard. So you need a reference. So you label it as red. Okay. Then you put your sample and the reference in these wells. Now what do you get? You will get these three colors are visible. Also along with that there is one grey color also which is visible. Grey means there is no copy present at all. There is no segment present. That is grey. Now what is yellow? First we know what is yellow. Yellow means that the patient and the reference have the same set of segments. If there are with a control, that means ideally if you should have two segments of a particular sequence and the patient also has two, then you will get yellow fluorescence in the well. Okay? If the control, if you are supposed to ideally have two segments or two copies and the patient has one extra copy, 3 copies, then it will fluoresce as green. So what you can see here, green, they are all having duplications. Okay, one extra set is there. If you are supposed to have 2 and the patient has only 1 copy of a particular segment, that is a deletion. So in case of deletion, what you get are red signals. So if the red signal is there, that means there is a deletion in that particular segment. So this is how you know. So you know which segment or what probe you have added in each well. You will know where it is hybridizing. You will know now whether it is showing a green signal or a red signal or a yellow signal. If all the wells are yellow, that means the person is not having any genetic abnormality. If there are any green signals, that means that particular gene segment is having a duplication. If there is a red signal, it means there is a deletion. So these CMAs are highly useful because they are first tier tests. That means the gold standard test for any developmental disorders. For example, if there are any delayed developmental milestones in a child, if the child is supposed to be having autism spectrum disorders, okay, or multiple congenital abnormalities, then chromosomal microarrays are the first what is done for these individuals. Mainly in case of DiGeorge syndrome, Williams syndrome and Prader-Willi syndrome. So these congenital abnormalities, we do chromosomal microarray. So if any individual who has come is lacking any clinical indicators, he is not having a specific clinical indicator, maybe he is just having a low IQ or having borderline autism disorder, you want to diagnose. So for that, to identify whether it's a genetic cause or a non-genetic cause, it can be something to do with the psychology of the child. Okay, maybe it is possible to correct through counseling. You don't want to brand the child as having a genetic disorder, so you want to do a genetic testing in the child. You can do the chromosomal microarray. So again, for prenatal diagnosis, if you are suspecting a microdeletion or microduplication in an individual, again mind you, chromosomal microarrays only give you the copy number variation. They are not useful in any other type of studies. Either it should be a deletion or a duplication, only then it is useful. So in case of cancers also, CMAs are useful. For example, amplification of HER2 gene in breast cancer. There will be amplification of this gene. So again, amplification means there is a duplication. So in case of this duplication of this gene in breast cancer, this is useful. Last is to evaluate the copy number variants in case of de novo balanced rearrangement or marker chromosomes. Anyway, marker chromosomes which are specific for particular specific disorders. Again, in them to know the balanced rearrangements, it is useful. CMAs now. I told you. Now, what is a balanced chromosomal abnormality? What is a unbalanced chromosomal abnormality? See, when you see here, there is 3 copies, there is 2 copies. That means the balance is not there. Okay, one place it is 3, one place it is 2. There is addition of a segment. Here there is a deletion of a segment. Again, there is no balance. Whenever there is a translocation, that means it is a balanced chromosomal abnormality. One portion of the chromosome goes from one chromosome to the other and there is vice versa shifting. That is a balanced abnormality. Whereas in this condition, it is unbalanced abnormality. So these chromosomal microarrays can diagnose or can detect only unbalanced chromosomal abnormalities. And it cannot detect point mutations. Okay? For example, in case of Fragile X syndrome or in case of sickle cell anemia, it's not able to diagnose it because it is point mutation. If there is one single gene deletion, it cannot identify. The whole segment or the whole copy of the gene should be deleted. So it is not designed to detect single nucleotide polymorphisms. What is the advantage? High resolution than karyotyping. It has got a very high resolution. Detection of submicroscopic genetic changes, that is microdeletions and microduplications. They can simultaneously screen the entire genome for the CMEs. So you can have the entire genome being screened, not just a small segment. You can do the whole genome for various abnormalities in the particular individual. So again, the copy number variation detection in complex conditions. Next is the denaturing high performance liquid chromatography, DHPLC. So it is again used to detect genetic mutations and variation sequence in DNA. So this DHPLC is useful for the point mutations and small mutations and point mutations, insertions, deletions, which is not happening or which cannot be done with the CMAs. Okay? The chromosomal microarrays which are not able to do the point mutation detection, the DHPLC is doing it. That means it is slightly more advanced than the chromosomal microarrays. Now what exactly we do here in the denaturing HPLC or high performance liquid chromatography is we have a column, that is a liquid chromatography column, and we pass the patient sample, elute the patient sample through the column. Before eluting, we denature it at high temperature. So there is high temperature to which the chromosome or the segment is subjected to, both strands of the DNA denature. Now, whenever there is a mutation, okay, or a sequence is changed, the melting temperature of that particular, melting point of that particular segment alters. That means if there is a sequence variation, that particular segment where the sequence variation is there will melt faster. Okay? When they melt faster, they move through the column faster. Understood? I hope I am being clear. When they melt, you are subjecting the segment of DNA to high temperature and causing the DNA strands to separate. That is called as the melting point. So when they have a sequence change, that means they are melting faster. When they melt faster, they move through the column faster. So you will get a peak much before what you are supposed to get. So this is how. This is the normal peak what you get when the particular segment is coming out of the column. But whenever there is a mutation, you will get an extra peak before the actual peak. That means there is a sequence variation where the melting point has reduced and it is eluting faster out of the column. So you get two peaks indicative of the change in sequence. So it relies on differential chromatography, retention of DNA heteroduplexes, post denaturation and renaturation. So where is this useful now? I already told you it is useful for point mutations, okay, single nucleotide variations. So in case of neurofibromatosis type 1, it is highly useful. It's a genetic condition. And in Huntington's disease, where you have CAG repeats, there is large number of CAG repeats. The CAG is the nucleotide bases in the HTT gene. So there will be multiple CAG repeats in that HTT gene, which is indicative of Huntington's disease. In this condition, this particular technique is useful. Also for genetic variants which can affect drug metabolisms like CYP2C9 and the VORC1 genes, which affect the warfarin metabolism. So again in this, because you are eluting it out of the column, it is very beneficial because you can study these genes better. So advantages of DHPLC, even small mutations and sequence variations can be detected. High throughput, you can put multiple samples together. You have so many patients you want to diagnose. You have a whole family whom you want to diagnose. You have different siblings of a particular individual whom you want to diagnose. You can put all the samples together because it is having a column and your code, it is based on the elution of the sample. That means the movement of the sample through the column. So you can pool these multiple samples together when you are doing it. Again here, you don't need DNA sequencing for this. You just need this strand of DNA which you are going to cut it using proper molecular scissors, and then you are going to elute those strands at high temperature through the column chromatography. So what is the limitation now? Complex mutations it cannot detect. Okay. Again, this is for simple mutations. A single point mutation or such things it can detect. That is not able to detect complex mutations. You require a proper optimization. That means you should have a proper condition set up for having this DHPLC. The temperature should be regulated. The column selection is needed. Again, the gradient conditions are needed. So you need a well-trained personnel to run the equipment. Alright? It can detect only sequence variations. Okay, structural variations, again like large duplications, deletions, translocations not able to detect. For that you have microarray. Is chromosomal microarray. So it is not suitable for all DNA sequences. Again, if the region is highly repetitive, in case of Huntington's disease, you can use this particular technique. But if it has multiple, a long read of repetitive sequence, then it will not affect the melting behavior of that particular segment. So that time, this technique is not useful. Next is the next generation sequencing. This is the what do you say, at present the best what is done for genetic testing. It is also known as high throughput sequencing. So it is a revolutionary technique that has transformed genomics by enabling rapid, large-scale sequencing of DNA and RNA. Again here, you can use RNA also for sequencing. So it uses either genomic DNA or the complementary DNA. Now what is the complementary DNA is that you use a mRNA, use reverse transcriptase enzyme and get a complementary DNA copy from that mRNA strand. So that is the complementary DNA. So it uses the whole genomic DNA. You can have a targeted or an exome sequencing in next generation sequencing. So what do I mean by whole genome? The whole fragment or the whole genome or the whole chromosome can be subjected to sequencing. But again, it has the longest turnaround time. What do I mean by turnaround time is from the beginning of the starting of the sequencing till you get the result, it takes lot of time, that it takes multiple number of days. It's not just hours, it takes many days for it to complete. And it is very expensive. The most expensive is the entire genome sequencing, and accuracy is very low because you are using the whole genome to sequence. Exome sequencing is when you use a particular exome. This is what I told you, and it is having a long turnaround time, but it is more cost effective than the genome sequencing. Accuracy is relatively good than the genome sequencing. Targeted gene panel is the best. That means if you know which particular gene is defective, then you isolate that particular gene and subject it to next generation sequencing. So you fragment those genes. This comprises around, the length of the fragment should be around 10 to 500 genes. The accuracy is very high. It is rapid, having rapid turnaround time, and also it is the most cost effective as of now, the targeted gene panel. And you can identify any type of mismatched sequence in targeted gene panels. So there are different types of next generation sequencing which is done. First is the Illumina sequencing. So it is called as, this is the most widely used, the Illumina sequencing. And here you do sequencing by synthesis. That is, you amplify the DNA fragments on a solid surface, then you attach the fluorescent labeled nucleotides, you incorporate it into the growing DNA strand. You do not fragment the DNA here, okay? Directly the fluorescent nucleotides are incorporated into the strand. It has got a high scalability and accuracy because again it is, you are sequencing the whole genome. It is having a long, not ideal because the cost effectiveness is lost here. Next is ion torrent sequencing. Here, during the DNA polymerization process, hydrogen ions are evolved. Okay? So this evolution of the hydrogen ions are the ones which are detected using the ion torrent sequence. So here, for this technique, you can use it as a targeted genome sequence for a targeted sequencing, and it has got a faster turnaround time. The next is the Pacific Biosciences sequencing, which is called as the PacBio. So here you use a single molecule which is having a real-time sequencing. So it is called a single molecule real-time sequencing. It produces a long reads. So this is beneficial because you can read up to 100,000 bases. So this is the latest development. After they started discovering limitations with the Illumina and ion torrent sequencing, these specific PacBio sequencing and the Oxford nanopore sequencing were discovered because there were problems with the techniques which were used previously to it. So it is useful for sequencing complex genomes. The PacBio, as you can sequence complex genomes and you can detect structural variants also along with it. And if you have any short sequence, that is, you are getting small segments which is difficult to read, that problem is solved by this PacBio because it gives you a very long reading sequence. That is, I told you, around 100,000 bases. Last is the Oxford nanopore sequencing, where you pass the DNA through nanopores. Okay, when you pass the DNA through the nanopores, you will measure the changes in the electrical current, which is going to determine the sequence of bases. So again, this is useful for long read sequencing, real-time sequencing. And for this Oxford nanopore, you have portable devices. That means you can use it in the field. Okay, you want to go somewhere, take the device along with you and go. It does not require a big setup. It is having portable instruments and you can take it for rapid field-based sequencing and applications. Now, what is the indications for next generation sequencing? To identify genetic variants, how individuals metabolize drugs by sequencing genes in drug metabolism. For example, CYP450 gene. For this, how it is involved in the detoxification of drugs, etc. It's ideal for knowing it. In case of clinical diagnosis of cystic fibrosis, in case of CFTR gene, Huntington's disease and muscular dystrophies. In prenatal testing for Down syndrome, again you can use this technique. And using, again you can use, I told you there are three types. The targeted sequencing, you can use it for detection of BRCA1 and BRCA2 genes for risk of breast cancer. For this also in cancer, you can use it. Now what is the advantage? High throughput. You get it very fast. It is very rapid what you can do. High resolution. It will allow you the detection of rare mutations, very rare mutations, small variants, complex genomic rearrangements. All this is done by the next generation sequencing. It can detect single nucleotide variations. That means it can, the previous techniques which were not able to do, one was able to do the point mutation but could not do deletions and duplications, whereas chromosomal microarray could do the deletions and duplications but could not do the point mutations. But this next generation sequencing solves all of that, because it can detect point mutations, it can detect deletions, copy number variations, as well as structural variants. All of this can be done using the next generation sequencing. So also it identifies genetic variations which affect drug response, susceptibility to diseases, also the treatment modalities. You are going to give a gene therapy or something to an individual and you want to know whether that gene therapy is working effectively in that particular person. You can do next generation sequencing and find out whether the drug treatment is working or the therapy is working for you. Now what is the limitation? Data interpretation. This next generation sequencing generates large amount of data and you require expertise, or you need an expert to analyze and interpret these results. Initial setup for the particular technique is large. You require, it is not very cost effective. You need it's very expensive for the initial setup. Short read lengths. So for short read lengths, it is not very effective. That is the Illumina and the Ion Torrent. So to overcome this, the Pacific PacBio and the Oxford Nanopore was developed. So this particular limitation is overcome by the PacBio and the Oxford Nanopore sequencing. So technical challenges. If they have repeats or homopolymer regions, multiple sequence repeats, then it becomes difficult to identify. That is, this NGS also are prone to errors if there is multiple repeats which are present in a sequence. Sanger sequencing is an ancient technique. It is not a recent development. But why this slide is there and why I have put it is, it was developed in 1977 by Frederick Sanger. But it is supposed to be a gold standard. That means even if I am doing a next generation sequencing, I have to confirm my outcome of the next generation sequencing using a Sanger sequence. Okay, whatever result I get out of the other technique, my confirmation will be with this old technique only, because it is having 99.99% accuracy. It is considered one of the best sequencing techniques, which was developed by Frederick Sanger, and it is called as the chain termination sequencing. So it is a gold standard. So this was used to detect and still is used, still in practice. It has not been outdated and it is being done. So it is detecting, you can detect point mutations, insertions, deletions, used to confirm the results which are obtained from NGS. You can sequence the mitochondrial DNA in forensic analysis for genetic testing of mitochondrial disorders which are maternally inherited, to diagnose or sequence small circular DNAs which are present in plasmids in case of genetic engineering, and for diagnostic testing of genetic diseases like cystic fibrosis, Huntington's disease. Also, because it is able to detect point mutation, we can use it in sickle cell anemia also. So advantages is very high accuracy and it produces high quality data, and it can read your long sequence. The long reads can be done using the Sangers. It is widely available. It's almost available in every research lab, maybe clinical or non-clinical. The cost effectiveness is good. It is not very expensive. The setup does not take much of a, doesn't burn the pocket much. But again, it also has limitations. Limited throughput. It is not suited for sequencing entire genomes. You can have long reads, but the entire genome sequencing is not very, the resolution is not good, the throughput is not good, and it is more time consuming. It can go up to many days. It cannot produce ultra long reads. That means when you are sequencing the entire genome, the ultra long reads will not be produced. That span the entire chromosome. If you want to very feasible for it. Again, if your DNA which you have and you are going to identify the sequence of a DNA has got more than 20% of a wild type of DNA, mutant DNA, then this can produce errors because it has reduced sensitivity in diagnosing whenever there are wild type of DNA present in the sample. Again, lacks quantifiability. That means it will not give you a proper number of how much of the particular sequence is having a mismatch. Third generation. Now what is this third generation? Third generation is same as the Oxford nanopore, but it has got a different name which is called as the third generation sequencing. So here you are going to direct the single strand of DNA and RNA through protein nanopores. You are going to pass them through the nanopores. When they are passed through the nanopores, there will be a change in the electric current by which you can determine the sequence. So it requires minimal sample processing. It does not require a lot of steps like amplification. In other techniques, you have to amplify the DNA, then you have to denature it, then you have to hybridize it with the probe, wash the probe, visualize it. It has got a lot of pre-preparation techniques which is required. But in case of third generation sequencing, you do not require all that. It is having a minimum setup also, and it is much easier compared to the other techniques. So it produces long reads. You can produce long reads in this similar to the Sanger sequencing. Like you can have deletions, if you have large deletions, duplications, translocations, all this can be identified. It has high accuracy, real-time results. Because of the change in electric field or the electric current, when you are passing the strands of the sequence through a nanopore, there is a change in electric field. Okay? That will give you the real-time data. That means as and how it is passing through the pore, here you are getting the data. So it is real-time data what you get. And again, in case of repetitive sequences or high GC content, again you can map it with these repetitive sequences also. It can be done. It does not require PCR amplification. So the amplification bias is not there when you are using third generation sequencing. That means the errors are lesser, the bias is also lesser. Now where do you apply this? Again, for genetic diseases, if you have any structural variants, that's variations in the chromosome structure, complex genome regions which are missed by NGS, the next generation sequencing, if it is not able to read anything, any particular sequence, then you can go for the third generation sequencing. You can identify mutations, gene fusions, structural variants. It can also sequence microbial genomes. So the microorganisms also can be sequenced. Transcriptomes. Not all of the techniques can sequence RNA. What we can do is, we take the RNA, mRNA, then we make a complementary DNA and we sequence it. But with this you can do the RNA sequencing, that is called as a transcriptome, where you can capture the entire RNA molecule and then you can identify splicing, the alternative splicing regions, the isoform expressions and the non-coding regions of the RNA. You can again, this is one of the feature of the third generation sequencing. Limitation is it's more expensive than the basic NGS, that is the Illumina and the ion torrent. It is more expensive. Higher rates, error rates compared to the short read techniques. The error rates are higher, but again it is more beneficial, more what you can do a longer read with third generation, but error rates are also there. So it's not like any method is perfect. All of them have their own limitations. So this is corrected, this particular problem is corrected using the PacBio. So to minimize the error rates, the PacBio was discovered. So the longer reads generate massive data sets that require advanced bioinformatics tools. Again, to analyze the data what is received, you need an expertise, you need different tools for that, you need to have various instruments for interpretation of the data. The last one in the lot is the single cell sequencing. So here, there are different types for identifying a particular, you take an individual cell in a population and you sequence. That is single cell RNA sequencing, single cell DNA sequencing and single cell epigenetic sequencing. So RNA, DNA, it is, the name itself tells you. Epigenetic means if there are any methylation or histone modifications which are there in a particular chromosome, this particular epigenetic sequencing can identify the changes in DNA methylation process. So for this now single cell sequencing, mainly it was started in cancers, to identify cancers. Okay, now it has progressed to neurological disorders also, like Alzheimer's disease, Parkinson's disease, autism spectrum disorders, then genetic disorders like muscular dystrophy, cystic fibrosis, sickle cell anemia, and also inborn errors of metabolism, that is the metabolic pathway disorders also are identified, can be identified using the single cell sequencing. Advantages, it's got a higher resolution, and you can identify rare cell population. So if there is any variant which is not found in other cells, and if it's a rare cell population, and you can track cellular dynamics also, what is happening inside a cell, all that can be tracked by single cell sequencing. Now what is the limitation? Again, it is expensive, requires specialized instruments, requires expertise. All of them require expertise and should be highly trained in reading or interpreting the data what you receive from all this. Generates large amount of data, okay, which is detected by sophisticated computational tools, and it's expensive. It's more expensive than NGS and the Sanger sequencing and third generation sequencing. It's very, very expensive for large scale studies.
Hello. Thank you, madam, for this very wonderful presentation. Yes. So, your explanation for all the detail started with Sanger 1977 and present NGS and even third generation sequencing also you have explained elaboratively. So, if you have any questions, please, madam is there to answer for that. Madam, I have some questions that you told on Down syndromes and especially the most commonly they use fish. So, NGS is more expensive. But what is the difference to identify through NGS and what is by fish?
Fish is not very expensive, so it is now become like every setup has got fish. NGS will give you the structural variant also. It will sequence the entire genome. Now you can do the targeted sequencing, you can do the exome sequencing and identify where exactly the defect is. So in case you want to target it for maybe any therapy or you want to try anything new as a therapy method, NGS is beneficial, but not all centers have got next generation sequencing. So ideally what is done is fish only.
Then you told some of the diseases embryonic manipulation can be done. So during before manipulation, if you identify an embryonic fluid, so you analyze it before the birth of the baby, can you manipulate that gene in the embryonic itself?
Manipulating the gene is not very feasible. Maybe you can terminate it if it is identified maybe before 22 weeks of gestation. Because legally, before 22 weeks
actually when it's usually when it happens, it's in adult stage or it's in by birth or
It is developed in later stages.
later stages. Thank you, madam. Doctor, sessions everyone. So in the lunch session, if they have any doubts, please they will have questions.
Thank you, ma'am, for entertaining us with your profound and insightful knowledge. I would like to thank Dr. Chandrasekhar B.M. and Dr. Veeresh K. Chandra for being here during the plenary session. I request Dr. A.R. Shabaraya, Principal and Director of Srinivas College of Pharmacy, to present a memento and certificate to Dr. Radhika Shenoy.
I would like to thank our management, our Honorable Chancellor, Dr. C.A. Raghavendra Rao, and Honorable Pro-Chancellor, Dr. A. Srinivas Rao, and our Principal, Dr. Shabaraya, and his entire team for giving me an opportunity to be here today. Thank you.
I also request sir to present a memento to Dr. Chandrasekhar B.M. and Dr. Veeresh K. Chandra. Thank you, sir.
Bangalore is known as an education hub. Many students from different places come to Bangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. Raghavendra Rao. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C. A. Raghavendra Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Bangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities, and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG, and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super specialty hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement.
I request Dr. Padmavati P. Prabhu, Professor, Srinivas College of Pharmacy, to welcome Dr. I request Mr. Ramdas Bhatt, Associate Professor, Srinivas College of Pharmacy, to welcome Dr. Srinivas Khan, sir, with a bouquet of flowers. I request Dr. Pooja Gopal Pujari, Assistant Professor, to welcome Dr. Krishnanand Kamath, sir, with a bouquet of flowers. May I now request Dr. Srinivas Khan, member of PCI, New Delhi and chairman of BOS UG RGUHS, to introduce the speaker of this session, Dr. Vijay Kamath, Senior Manager of Pharmacovigilance, Micro Labs, India, Bangalore, to the gathering.
Good morning to everyone here, and welcome back to this session of Mr. Vijay Kamath, who is a highly experienced pharmacovigilance center risk management professional with over 13 years of expertise in clinical and post-marketing drug safety. He is currently working as Senior Manager, Pharmacovigilance at Microlab Limited in Bangalore. His work focuses in ICSR management, signal detection, risk management, plans, regulatory compliance, audits, and inspections. He is passionate about ensuring patient safety and regulatory adherence while leveraging AI and automation to enhance efficiency in pharmacovigilance. Vijay holds a Master Pharmacy in Pharmacology from RAJIV University of Health Sciences in 2009. He passed out. Throughout his career, he has held key posts in leading pharmaceutical and healthcare organizations including Tech Mahindra, Quintiles, Inventive Health Clinic, Tata Consultancy Services, and Cognizant. His vast experience covers pharmacovigilance operations, aggregate report writing, audits, safety reporting, and regulatory compliance with FDA, EMA, and SCH guidelines. Mr. Vijay is proficient in multiple languages including Konkani, Marathi, Hindi, and Kannada. His expertise, leadership, and commitment to patient safety make him a valuable contributor to the field of pharmacovigilance. With this brief background, I invite Mr. Vijay Kamath to deliver a talk on integration of advanced technology in pharmacovigilance. Please.
Thank you, sir. Thank you, everyone. So, first of all, I would like to thank Srinivas College Management for organizing this event, and Dr. Shabraya, sir. I'm his student, okay, and also Ramdas and other faculties. Thank you for organizing this event and giving me an opportunity to talk in this event. Okay, thank you. So, what actually fascinates me, working in the pharmacovigilance profession over a period of time is basically when I looked at the title of this conference, which has at the end patient safety, right? So we do everything, right? Ultimately, where we end up at the patient safety. So we want to be a safer side, right? So when we take any medication, what we expect? We want to be safe, right? So it should not do any harm to you, right? If it gives the benefits, that's absolutely fine. If it reduces the fever, that's absolutely fine. But it should not cause you a diarrhea, right? So that's what we expect from a medicine. But definitely it's not the case. Each medicine comes up with side effects as well. And in patient safety, what we do is try to minimize the risks of these medicines. So how do you minimize the risk of a medicine, right? So there are big terms like a risk management plan we give to whenever we give for, when we take an approval for a drug, we give a risk management plan, right? Authorities will ask for a risk management plan, give a risk management plan, how you will manage the risks associated with this particular drug. So in a very simple sense, if I would like to tell you, the risk management tool that we all know is when you open a pack of any syrup, right, which you use for cough and cold, right, there will be a leaflet inside. We call it the patient information leaflet, right. It's a very layman words. It would be there and it will have the data when the drug should be used, for what condition, what the indication, when it should not be used, right? It gives you information about contraindications, drug interactions, everything. So that is a risk minimization tool, right? So everything that we do here in patient safety in pharmacovigilance is to ultimately leading to updating the labeling of the of that particular patient information leaflet, right? So that is a patient information leaflet is in line with what we call an SMPC, right, or SPC. That is a product information, right? Each company has to manage one product information for one product, right? and this product information will have the data the medical terminologies will be there in product information, SNPCs. So physicians can get these SNPCs, they could able to understand. But what about common man? So there is a, there is a patient information given, right? So I just, informed you what activities we do in pharmacovigilance. Ultimately, it leads to the risk minimization of the drugs and updating of the labeling of the drugs, and finally, leading to, making the patient aware what it causes, what the drug causes, right? So that is the significance of pharmacovigilance, right? So the topic that we are discussing today is about integration of advanced technologies. So I will just give you an overview of pharmacovigilance process that we handle. Currently, I am employed with microlabs, right? I manage pharmacovigilance for microlabs. So here we do end-to-end pharmacovigilance activities. So mostly, the technologies which are integrated are in our safety database itself, right? So there are the safety database is integrated with the OCR engine and other technologies which will facilitate us to process the cases on a daily basis, right? But to take you through that, I will just give an overview of pharmacovigilance, why technologies are playing a key role in pharmacovigilance, and then I will present you two interesting demos, right? One demo is with regards to a robotic process automation, which actually I was a part of a solution which we developed for a Japanese pharmaceutical company, where I played a key role in, as a solution architect for that solution, right, to designing that solution from end to end. So it is a technological play that we did, and we created a solution to address a particular need of the customer, right? I will speak on that particular aspect, right? So these are another demo that I have designed for you to look, that's kind of a demo which will give you a perspective how technology can be used effectively and efficiently in pharmacovigilance, or it might be in a day-to-day life or the activities that you are handling academically as well, right? So let me start this. So introducing you the pharmacovigilance, right? Pharmacovigilance is the science and activities related to detecting, assessing, understanding, preventing adverse effects or other drug problems. As I mentioned, we detect a new signal or a new risk associated with a drug. If the risk is not already updated in your labeling documents, we check those risks. We continuously do a monitoring of the safety reports that we get, and based upon if the risk is actually related to the drug, establishing that the relation between the drug and the event is more important, in pharmacovigilance. That we call as a signal detection, right? Signal is nothing but a strong, if there is an adverse event, we should have a strong evidence to prove that this adverse event is caused by the drug, right? So that we call as a causal relationship. So if you go to any interview, for example, you will be basically asked what you mean by causal relationship. That's the important basis for pharmacovigilance, to establish a link between an adverse event and the drug, right? So, so that's what about the detecting, assessing, understanding, preventing adverse effects. So we detect the adverse event, we detect the new risks, we understand, we do, we collect the sufficient evidences about that adverse event over a period of time, that we do a drug monitoring, and further we try to prevent those adverse effects. How we do? By informing or not using those medications if a particular adverse event is specifically occurring to a female patient, right, during the pregnancy. Okay, there will be a contraindications will be given, right, for that drug to be used in the pregnancy, right? So that's how it will prevent the adverse effects. It will minimize the risks if you are aware that it causes a risk, right? So this safety is a very critical factor for a pharmaceutical company, right? So if a drug has any kind of a safety issues, right, it might be a quality which will lead to a safety, right? If a person takes a particular medication and experiences an adverse event, he don't feel safe to use that medication again from a particular pharma company. So it is important for a pharmaceutical company to sustain their medication should be safe. Whatever they are manufacturing, they should have a proper GMP and follow a GMP guidelines. That is, GMP is good manufacturing practices. At the same time, good pharmacovigilance system should be in place to ensure that this, the medicine is safer to use, right? So, drug monitoring, safety is a critical factor for any drug to sustain in the market. How we do that? Pharmacovigilance, we do continuously monitor. That is, we call as a routine risk minimization activities. So we continuously monitor a particular drug, right? So this basically helps us to do an informed decisions. Further, we inform to the authorities about any risks associated with the particular medications, and it helps the authorities to take a decision whether that you might have seen some drugs getting recalled, right? You might have seen some drugs getting banned, some drugs getting suspended, right? Because you have to, if there is a suspension, you need to prove the quality of the drug. If it is a safer, safety has to be proved again to make the drug work again in the market. So that is the challenges. So what are the key responsibilities in a pharmacovigilance department that we have? Already, as I explained. So as per the definition, we detect the adverse event, right? How we do that? We collect the information, right? So safety data collection from multiple sources, right? There are multiple sources through which we get safety data. It is very important for an HCP, okay, healthcare professional or a physician. If you are visiting a physician and he notices any adverse event, he directly reports to the pharma company or to the regulatory authority that a particular patient has experienced this adverse event. He was on this medication, he had this kind of a medical history and concomitant medications. So we'll come to know, about the adverse events. That's how we detect. Then also the consumers, but consumers also report, right? But HCP reports are considered as a more valid, authenticated, because it comes from what you call as a medically confirmed reports, right? It is a more authentic when it comes from a healthcare professional, right? Apart from that, we do, as per the regulation, you might have the guideline, the Bible for us is GUP, good pharmacovigilance practices. So as per the guidelines, the GUP is basically a guideline provided by European Medicine Agency, right? You get that access and you can review the guideline. So GUP 6 is the guideline that we follow for ICSR processing, that is collection of the adverse events, described in this SOP. So we, in this directive, that's a guideline, that's a directive. So based upon this directive, we design an SOP. So based upon that SOP, we do activities in a pharmaceutical company, right? So literature, as per the GUP 6, a pharmaceutical company has to perform a literature review every week, right? So from this particular period to a week's period, we do a literature search. Where we do literature search? In databases like PubMed, Embase, or any particular like ADS Insight are the databases which basically used to do a literature search. 1,000, we get for each molecule 40-50 articles, and then we segregate the articles which are relevant for us, because if there is any causal relationship, as I mentioned, there is any relationship between the drug and the event, such articles only we will focus on, right? So there are many companies coming up with this automating this literature search process, but currently these solutions are not that effective enough, because in pharmacovigilance we require 100% quality. The there is no option of 99% as well, because one article might be so significant, right, leading to a signal or a risk. So it becomes difficult even for the advanced technologies to interpret, because it requires some kind of a human intervention. But definitely over a period of time, the companies will gain, success in doing it 100% as well, right? During this literature reviews. So social media is another platform. You post some adverse events on Twitter, for example. So it is as per the regulatory requirement, it is mandatory to monitor social media, right? So to highlight any adverse events. And so this is the safety data collection from multiple sources is one of the activities, key responsibilities that we do pharmacovigilance. Apart from that, the data that we collect is basically analyzed further. Risks and benefits of the drug are analyzed, and then the other key responsibility is ensuring the compliance with the regulatory requirements, reporting everything. There are as per the guidelines, we need to report adverse events within a specific timeline. So ensuring this we call as a regulatory compliance, right? So following up with the regulations, what is set by the authorities, regulatory authorities, to ensure that we are following their compliance. It's called regulatory compliance. So when you see inspections happening, right, majorly in pharmaceutical companies, these regulatory inspections happen, especially with regards to manufacturing plants, and when it comes to the R&D side, it comes to the safety side. So safety department, pharmacovigilance department is generally inspected by authorities like FDA, US FDA, MHRA, other authorities inspect. So they essentially check whether the pharmacovigilance process is in line with the regulatory requirements. So we continuously need to ensure that we comply with the regulatory guidelines, right? So, and also we need to continuously monitor the adverse events, report it to the authorities. So that is another responsibility of us. These are the key main responsibilities. So if you see the current process overview, okay, this is with regards to, there are two things, right? One is pre-market and post-market. Pre-market need to be, drug safety need to be performed, and post-market drug safety. Both are important, right? So in pre-market, basically when a clinical trial happens, two things we look at, right? One is efficacy, one is the safety of the drug. So here the main person who reports the adverse events is the investigator or trial sponsor. It is his responsibility during the clinical trials. If there are any serious adverse events happening with the particular drug, right? Investigational product, if there are any adverse events are caused by the investigational products, the investigator or trial sponsor will come, inform it to the pharmaceutical company, and and pharmaceutical company once receives those reports, they further process. So this is safety data processing. So if they process the report, we maintain a safety database. It is kind of a repository, right? Safety database is a repository where all the adverse event reports are saved. So this safety database is basically able to integrated with advanced technologies nowadays, where we could able to directly pull the reports, where we could able to directly detect the signals, right? So they are integrated with so many capabilities. So that basically essentially helps a pharmaceutical company to monitor the drugs are monitored on a 6-monthly basis, right? So during that process, it basically facilitates the technologies. So apart from that, once the safety database, if the case is processed in the safety database, further based upon the requirement, it goes to the periodic report or an ICSR, individual case safety report. So if it's a serious, so one of the challenges that we face is each country has a different regulations when it comes to reporting adverse events, right? So based upon that, we have a scheduler in the database, we have a scheduler where we've been able to schedule the reports. If it is a serious, unexpected adverse event that needs to be reported to the US FDA. If there are any serious cases, irrespective of expectedness, unexpectedness, we need to report to the we need to report it to MHRA and European Medicine Agency, right? So the databases are designed in itself in such a way that when there is any adverse event or when we process any reports, when it required to be submitted, it automates the process of submission. So as I explained, these are the main with regards to the current process of post-marketing safety. So post-marketing safety basically involves us to collection of data, as I already explained in brief, right? So spontaneous source like call centers, emails, fax serve as a source for spontaneous. Spontaneous is nothing but where the report directly comes from a physician, consumer, right? It's a spontaneous reporting. And solicited is basically organized programs. Pharmaceutical companies will have programs, right? So basically when there is a drug costing very huge or for a rare diseases and the drug is required, the patient required to be prescribed the drug on a weekly basis or bi-weekly process, there is a continuous monitoring of such processes. There are different types of patient safety programs will be there. So where a patient has to report the adverse events to the pharmaceutical company, right? It becomes mandatory whenever there is an adverse event, patient has to report. So it's an organized system of reporting, right? So that we call as a solicited reports. Then literature. Literature is a very big source, right? So we publish so many literatures. Even you will publish literature, right? Once you done with your project work, you will publish a literature, right? So the pharmaceutical companies keep on monitoring these literature reports through the different databases like PubMed, Embase as I mentioned, right? And we have to review it. So this is a very challenging task because a person has to review it for half an hour, literature, then he has to assess whether the literature has any relevant information related to pharmacovigilance, right? Any relevant information in the sense there are 4 important things to consider as an individual case safety reports. There should have a valid patient identifier like patient age, right? Patient gender, these are patient demographics should be there. The reported information should be there, right? An adverse event should be there. A suspect drug should be there. Suspect drug is nothing but my company drug, right? Our company drug. So other company drugs, we basically, if it is not directly related to the adverse event, we call it as a concomitant medications, right? So why this all information is needed? Because to prove that our company drug is, for example, for us, it's important to prove that the adverse event is not associated with my drug, right? So that I will have a patient, for example, there will be a patient reporting, okay, I had a hypertension, diabetes 5 years back, and now I am having frequent urination, okay, and I am taking your drug from the last 2 years, okay. She will give this kind of an explanation, and apart from that, I am taking a number of drugs like I took last week. I had a fever. I took paracetamol, and many examples, clopidogrel I take, and many other drugs she is currently on, right? Concomitant medications. So when we prepare any kind of a report, so basically we need to prove that the drug is might be associated with their medical history, or might be associated with their concomitant medications that they are on, right? So and also it is important for us to prove de-challenge and re-challenge, right? For a drug, the literature article should have a de-challenge and re-challenge. De-challenge is basically, when you stop a medication, the adverse event should stop, right? Or it might continue. Right? If it stops, we call it a positive de-challenge. If it continues, we call negative de-challenge. Re-challenge. And then for more confirmation, there will be a re-challenge. So you initiate a drug again. Once adverse event occurs for a patient, was taking, for example, aspirin, right? He had a headache. He stopped the medication. Adverse event stopped. Once he initiated the drug again, adverse event again started, right? So now it proves there is a more possibility that the adverse event might be because of the aspirin, right? So such kind of an information like re-challenge, medical history, this plays an important role apart from our product information, which maintains if a particular adverse event is new to us, right? There are two things based upon that a signal is detected. An adverse event should be new to us and it should have a different variety. Earlier, the adverse event was, as per the SMPC product information, the adverse event was rare, right? For example, drug clopidogrel has agranulocytosis. It was a rare adverse event. Now, we have in the last few months, we have seen this adverse event getting reported more frequently, right? So now there might be a chance that this adverse event has changed the nature from rare to more frequent, right? So in SMPC, the same thing needs to be reported, right? So this is a kind of a risk which needs to be further evaluated. So basically, when we identified any signal, we assess those signal again for a period of 5 years to determine whether it is a confirmed signal. If we don't get any strong evidences, if we get strong evidences for the first time only, then also we consider it as a signal, validated signal we call it as. So a similar process where the collection happens, only the reporting part changes. In clinical trials, basically the report comes from the investigator or sponsor. In post-marketing, we collect the information from different sources. It comes to the pharmaceutical company and processed in the safety database. We have various processes like a triage, data entry, query process, QC, MR, case closure. So these are the triage is basically specifying whether that adverse event is actually related to our drug or no, right? Further to that case needs to be entered into our safety database or no. Such key decisions we do in a triage, and further if it is relevant data for us, further we enter into the safety database and perform a data entry, quality review, and further it goes to the medical reviewer, who is a company physician who writes comments on that particular drug, whether there is an implication whether the drug is related to the adverse event or not, right? And further, this data is further used for preparing periodic adverse event reports that we need to submit to the authorities, and signal analysis. This data serves as a repository for us. So current challenge in pharmacovigilance is, if you see from the adverse events, as per US FDA data, total number of reports generally increased from 2017 to a peak in 2022, right? Following the 22, there was a slight decrease in the report count, right? In 2023, with number remaining relatively stable in 2024. That's might be because of the COVID, but at the same time, yes, there is the reporting or the awareness of pharmacovigilance is increasing, and reporting is increasing. That is the reason we are getting more reports, right? When you get more reports, more people get employed, right? So that's all about. And that's one challenge. But how this high ADR volume is impacting pharmaceutical companies? Pharmacovigilance, to be frank, is a kind of not a value generator for a pharmaceutical company, right? So they are more focusing towards the advanced technologies to take care of these processes. So, but still, human intervention is required. It's not that all the end-to-end tasks will be done. Most of the companies nowadays do that end-to-end tasks will be done by bots or AI. But currently, it is still not 100% achievable. So that is the one reason why the higher volume of the data is a challenge for us. Second is labor-intensive, error-prone manual processes. We do manual processing. So main challenge that we face in the data is the data that we do. When we do a manual processing, we have a tendency to do an oversight error, right? If you ask a machine to put data from A to B to C, right? Whenever you enter that button, it automatically puts the correct data. But humans will do an error. He might be thinking something while entering the data, right? Or he might not be focused while entering the data, so he might do an error there. So manual errors have increased a lot. That's one of the challenges that we have. And noisy, unstructured data from diverse sources, like social media. We have to monitor as per the regulatory guidelines. But social media data is so noisy, right? So sometimes there will be a vague terms which we could not able to understand, or there might not be a clear indication who is the patient, who is the reporter. So it's kind of a noisy data that need to be cleaned up. So it takes a lot of efforts. And lack of data harmonization, local pharmacovigilance. We are doing a global pharmacovigilance, right? For example, Macrolabs is, we are selling the drugs to US, Europe, UK, and many other ROW, that we call rest of the other countries, like Africa or Arab countries, right? But the challenge that is facing is each country has a different regulation. Each country reporting requirements are different. Each country has a different requirements when you take an approval for a drug. Each country has different requirements when you write a pharmacovigilance system master file maybe, or prepare a report. The template variations are there, reporting timeline variations are there. There is no harmonization. That is another challenge that pharmaceutical companies are currently facing in pharmacovigilance. So the key technology revolutionizing PV. So I got an opportunity. So I was a core into the pharmacovigilance, working core into the pharmacovigilance. I never got an exposure to these technologies earlier. So when I joined initially I worked with Cognizant in it was a pharmacovigilance call center where we would get reports directly from the physician and the consumers, right? So nowadays these call centers are also getting automated with bots in place. If bot will, when you call, you might have seen in many Indian companies also, banks and other Amazon and other, when you call a call center, initially a bot will answer or bot will respond. So if a bot fails, then a customer will take the call. So when a bot takes the call, he directly takes all the information, and further when he takes the, when a bot takes the information, it will be more structured in nature, and it can easily processed in the next workflows, right? So I was working for a pharmaceutical company in Japan, Hitachi Pharma. So then they come up with, can you develop a technology for us where where you have to automate a particular task. So I came back to India at that time in 2000. It's the story of 2018. I came back to India with our team of AI and RPA, developed one a system where we could able to automate the tasks, whatever the challenge the customer had, and we resolved with the automation. It's an end-to-end automation. So not an end-to-end pharmacovigilance activity. It's a small activity that need to be automated. That can be done. If it is a very structured data and the processes are well defined, you could able to automate that particular activity, right? If the activities are well defined, like A, you are clear with the A. It's a very structured. If P is structured, C is structured, you can automate the whole process, right? That I'm going to show a demo for that. So before that, I just wanted to come to the key technologies. So robotic process automation. So this robotic process automation, there are a few tools you can also check on the Google also. You get an information UiPath, right? Automation anywhere. So these are the tools which are specifically designed to do automation activities. Also the new coding languages like Python is mainly used to automate. So with Python also you can develop a robotic process automation. But frankly speaking, I am a core pharmacovigilance, my area of specialization is core pharmacovigilance. I don't have a much deeper understanding of the coding and other parts. But definitely, if you would like to work in, definitely today requires you to work in, two different departments. You have to collaborate and work, right? So definitely you have to have knowledge about the other technologies, right? But the basics of, I always ensure that the basics of the student should be strong enough with regards to pharmacology, right? Pharmacology knowledge should be very strong, then only you go for a pharmacovigilance, career, right? So coming to the RPA, it automates the repetitive tasks. So nature is repetitive tasks. So you enter the data every day, it's a repetitive, it's a boring task. You come to the office, you get a form, you enter the data. It's a repetitive task. So you can map those fields, right? If there is an SBI form, every day, name you have to fill, age, date of birth, everything, then you can automate that process, complete process itself, right? So automatically the data can be entered. So this robotic process automation has the capability to automate a process, end to end. It reduces the errors and improves efficiency, right? Automated data entry of ICSRs, auto coding of adverse events with MEDRA. MEDRA is basically we use a medical dictionary for regulatory activities that is used to code the adverse events, medical histories, labs can be coded with the MEDRA. ODD is basically WHO drug dictionary we use. It's a very, to have a uniformity across all the companies we use with these dictionaries. WHO dictionary is used to code the drugs. Then the other technology like optical character recognition, OCR, we are currently using, right? When you are using an Adobe, it basically able to do an OCR recognition. Then when there is a scanned document, you run a OCR recognition, then you could able to copy those texts, right? So OCR engine like Tesseract, AVI, Cloud, Google Vision. Now the engine which I used during my work was AVI. AVI used to do almost 99.9%. It could able to extract the exact data if it's a scanned document as well. So that kind of optical OCR engines we have today. Natural language processing is basically employs in computational methods of learning, right? Natural language processing that we use in generally when you use any Siri or any other application, right? Google also, Google Talk, right? When we communicate with, now Gemini also has that chat, right? The bot will communicate with you. That is basically the technology of NLP, natural language processing, where it can able to speak like humans, employs computational. So this basically helps us to extract from the social media, medical narratives, and it also helps us to identify duplicates and classify reports. So and the next technology is a machine learning technology, right? So it enables system to automatically learn, improve from experience, recognize patterns and perform predictions. It automates pharmacovigilance tasks, including handling safety team mailboxes, categorizing adverse event mails, determining adverse drug reaction signals in signal detections. So machine learning can able to do a categorization of the emails. We have a safety mailbox where we receive the adverse event reports. So if you automate that particular task, that automatically it will review and it will take the data from it and move to the next process. And natural language generation, right? You nowadays ChatGPT you input some data there, you ask some question, it responds, right? It is nothing but natural language generation. It generates the or you use the translations, right? Automated translations. That is nothing but natural language generation. So how it helps is most of the times we get the data in Spanish or any other adverse event reports. That data translation and other activities can be automated with energy. And also it helps us to write safety narratives. When we have the data, I will show you the demo of how it writes. So when we have data, it writes safety narratives as well. Then blockchain technology, it's an end-to-end technology which basically gives more transparency, security and traceability of pharmacovigilance data. So pharmaceutical companies basically have co-partners, co-marketers. For example, if McLabs is manufacturing a drug, right, in India, and we are selling it into France, so there we will have one marketing or a distributor, right, who is not linked to McLabs, but we have a partnership with them. So there we form an agreement with them, and further if there is an adverse event reported to them, that needs to be reported to us. How this can be streamlined with pharmacovigilance agreements. You might have heard safety data exchange agreements. These are very important. One of the important department will be there in pharma companies, safety data exchange agreements. So the basic work there will be ensuring these agreements are in place as per the agreement timelines. Those co-marketers or distributors are sending the reports to the pharmaceutical company, adverse event reports to the pharmaceutical company. So so this is blockchain technology can be integrated into when we have multiple licensing partners, right? And it becomes difficult to manage the data transaction between each of them. At that time, I think blockchain technology will play a key role. So it can provide an immutable record, safety, reducing risk of data tampering and improving audit rate. Then comes AI and advanced analytics, right? Predictive analytics. AI can be used to predict potential safety issues by patterns that may not be apparent through traditional methods. AI algorithms can be trained to continuously monitor data sources for potential safety signals, right? So AI technology has the potential. Now we are using tools like signal. For signal detection, we use a signal empirica, which statistically provides the data. If there is, for example, 100 case reports or 1000 case reports are there, it becomes difficult, right, to go through individual case reports and then analyze. So which adverse event is related to which one. So if we set up a one-time algorithms which could able to facilitate us, give us a signal, there will be a signals, there will be a scoring. So they could able to provide a scoring to us. So based upon the scoring, if there is a higher scoring, there is a potential of risk associated with this particular drug. So we could identify which case report has that particular data. So that's how AI predictive analytics can be used to understand the safety issues in the signal reports. Cloud computing. So nowadays most of the safety databases are cloud in order to secure, because patient safety data is something which is require compliant with HIPAA and other GDPR guidelines, right? Data protection guidelines. So there is a chance of scam, getting hacked and other things. So in order to prevent that, cloud will facilitate. Also, the cloud environment will improve the flexibility and scalability. Because the data that we consume in the database is a very huge data, because it continuously feeds with the data. So cloud has the capability to handle such a process. Right? So I will showcase one case study where so these technologies, what we tell, right? We can't use these individual technologies. When we come to there's a combination of technologies will play. When it plays, combination will be used, right? So if you see robotic process automation, ML, OCR, NLP, energy, see all this will make automation possible in pharmacovigilance. So one of the case study I want to present is a company receives around 4,000 to 5,000 adverse event reports per month in multiple different formats from multiple global licensing partners as per pharmacovigilance agreement. So when a report is received from a licensing partners, they from the other companies, basically licensing partners are other companies which sends the reports to us. They are mostly structured reports. You might have heard SIOM's form, right? So if we have an agreement with a pharmaceutical company that you have to provide us a report in a SIOM's form, then they will provide us in the SIOM's format, right? It's a very structured format. It's not a written format, it is a printed format, right? Why I am emphasizing on format is that structured formats are more easy to automate than unstructured formats. A large volume of adverse event reports from the company used to receive around 2,000 to 3,000 reports per month, and it becomes difficult for them to handle the processing. This safety reports, when they come, they have to be entered into the safety database, right? A manual work is needed, data entry is needed, and data entry person might do oversight errors, okay, to rectify that. Again, a QC is needed, quality reviewer is needed, right? So it will increase the labor, right? To decrease the labor, they wanted to automate this process. So manual processing of ICSR is also time consuming and requires 30 to 45 minutes. So each case takes around 30 to 45 minutes. Okay, and manual processing will lead to time consuming, error prone, right? And more efforts are required. So the RPA based application, so we thought, I was a solution architect for this. So I thought, I understood the reports, how it comes, which are the channels through which it comes. So based upon that, we thought of designing one application for them, which has the capability of RPA, OCR, NLP, ML, and energy, right? So here the automated pharmacovigilance solution, the RPA application provides an automated solution of pharmacovigilance process, SIOM's file processing and safety information extraction. It receives SIOM's files and extracts safety information. So this SIOM's files, data need to be extracted, entered into the safety database. That looks a very simple process, but it is tedious when it comes because it has a patient safety data in it.
You can take this. Vijay.
The RPA, Django, and machine learning, optical character recognition. So we use these technologies in order to facilitate this application. So this application looks like this. So I'll take another 10 minutes. So the application looks like this. So if you enter the information, then we have kept here AE mail server, OCR server, RPA server, validation server. So the data when you safety mailbox to receive the reports, then it automates when you initiate this bot, okay, automatically it fetches the email into the application, and further it basically processes this data, where automatically it creates a virtual form, source document. Further, once the source document is created, further it extracts the data, right? The machine will automatically extract the data. You can see here patient date of birth, patient age, and further it can able to create a virtual SIOMS form. Then we have a validation process where we validate the data, where both the forms, a virtual form and the form which is a PDF format, we compare the data. This is a manual process we have kept because the automation cannot ensure 100% quality sometimes. So once this data is processed, further it automates the process into the Argus safety database. So it enters the report type, country, initial received date. So this automates the complete process. So another, as I mentioned, literature review, it takes a lot of time, and it's a time-consuming and tedious task that we do. So I will just show you a model, a demo, how it basically works. Can you start the demo? So these are the different technologies which will play. I am using an open source model here, DeepSeek. You might have heard a lot about it, right? It challenged recently, DeepSeek challenged basically the ChatGPT, right? So it is more effective in doing the task, but let us test once. Yeah, so I have taken here an example, a literature article, atorvastatin-induced refractory thrombocytopenia. So this is a literature article, which is a valid literature article. It is a case presentation, 69-year-old female experienced the adverse event, and it has history, medical history, adverse events, all the data, which is relevant to the pharmacovigilance. So let us see. So this is the article. I'm just giving the example. It has a discussions. It's a lengthy article, right? It has all the, it's a full text article. So this is a SIOMS form, right? So it has a different data fields, 1, 1A, 2, 3, 14, 15, 16, 17. So these are all data fields that need to be completed when you fill an adverse event report form, right? 24A, 24B, 24C, 24D. So each section is important from the perspective of pharmacovigilance. So now I will import this article into DeepSeek and give it a prompt. Okay, analyze the article, analyze and review. Analyze and review from the pharmacovigilance perspective. So the prompt plays an important role because you have to give a clear direction to the AI to facilitate the further extract the information and given in the COUTS form. And provided the different data elements which are there in the COUTS form. Now I am giving a prompt to extract the data. So the bot automatically the AI will pick up the data, country, age, patient gender, suspect drug, dose, route of administration, therapy duration, all the critical information which is required from the. So this task basically takes how much time if everyone does. It takes almost 30 minutes. He has to review through the article, understand, and then he has to there are chances that he will make mistakes also, right? Oversight errors also. So this is how it is done effortlessly, but definitely we can't rely on AI completely, right? So this acts, as per me, it acts as a facilitator. It will definitely facilitate us in our routine activities. So once this is done, can you make a video a little faster? So this is how the suspect drug is atorvastatin, daily dose is 20 mg, route of administration, concomitant drugs, okay, none mentioned, and initial report, literature source, and also it determines the causality assessment, Narinjo score 8, which is probable. The drug is probably related to the adverse event, right? It has all the relevant information. So once this is data you will get, structured data you get, further you ask the database to write a safety narrative, patient safety narrative. So on this basis of information, write a safety narrative. So it's automatic the narrative, right? So you just give a format to it, it writes a narrative for you. And there will not be errors as well, right? This is the play of how technologies are actually disrupting the pharmacovigilance market. So many companies are interested to do a lot of activities related to AI, and definitely when you enter into the market, you might see a lot of new innovations which will come out. But at the same time, I just wanted to highlight the AI technologies still are in like a baby phase. They cannot be used because, as I mentioned, 100% accuracy is needed. They could not able to ensure 100% accuracy, and also as per the regulatory needs, there should be a transparency. Transparency means regulator want to know what you are doing from A, B, C, D, E, F. So some of the AI technologies are black boxes. They will not tell, they will not reveal what it does, right? So there is a chance of missing out of data. If you tell me to extract the data and provide, they might miss some important information. So there is a kind of what we call trust. Trust is not there still. So that trust might build, needed more time to build. So currently, I just thought to show you this demo in order to make you understand, next level how it would be. Yeah, can we go to the presentation? Yeah, so at the end I just wanted to commit the power of technology to revolutionize the pharmacovigilance is undeniable, but at the same time there are currently challenges. So it is our collective responsibility, right, to embrace these advancements, to invest in the development and ensure their ethical and effective implementation. So there is something called the AI this will take place once, in future might be. So currently, companies are still working on, building these activities to make it a full-fledged, a successful model. So when you go into the market, you might see more advanced technologies. So having said that, I just wanted to conclude the session. Thank you.
Thank you, Mr. Vijay. And the session is open and we are running short of the time. Maybe one or two quick questions if there is any we can take.
Now, anyone has any question?
If there is no question, I will ask one question. Here, Mr. Vijay, here.
Sorry.
Somehow he is so grabbed with the audience that he is not looking this side. All this is fine. You have done a beautiful job of presentation from very basics to very advanced and demo and all. It's fantastic. But I just have a doubt. It's a very layman question. Okay, you collect all the data and sometimes patient-specific reactions also will be there, which you generally term them as rare reactions. And but after collecting the data, what exactly the company will do? Of course, they will not change the molecule, or maybe if it is very serious, you will withdraw it. Otherwise, what do you do with the company when you get all this data?
So, if you listen to my minds, I initiated the talk with the risk minimization. So, ultimate goal of patient safety is risk minimization. So, we do a risk minimization. So, based upon the general rules that are in risk minimization is SFPC, patient safety pin, right? We continuously update that patient safety pins. So, regulators also ask us to update this product informations. So, how it affects is, in India, see, it is our responsibility to check whether the medication I'm taking, what contraindications it has and other things. But we are not checking in India. But in other countries, definitely in US and other countries, patient report that it has been mentioned in the patient safety leaflet that it should not be taken in this. So shall I take this medication? It has a starch in it. I am allergic to starch. So shall I take this medication? So that kind of an awareness is still not in our population, I would like to say. But we need to move that stage, in one time, because if you see UPI, Pharmacovigilance Commission in India, so they have set up almost 1,500 plus monitoring centers in India recently. Means the last, I think within the last 5-10 years, they made this advancement to set up many data monitoring centers. But definitely, the reporting, with regards to reporting awareness is not there. So Indian population means even when we take any medications and experience any diarrhea, for example, we associate it with any drug, like any food, instead of associating with a drug and reporting to that company. And if we report to the companies also, since our regulators are not that stringent with the regulations and other things, the company will also not neglect those. Sometimes they also neglect. But some companies like Unified Macalabs has a separate department for pharmacovigilance India. But we get a very less reports there, right? So if you see the total reports that we get is around 1,000, 5,000, 6,000 per year. Being a small pharma company, we are getting 4,000, 5,000 reports. From India, we get almost 100 to 150 reports. So that awareness, even though our population is almost equivalent to, combining US and Europe, our population is more than that, but still our reporting is very less.
Yeah, that was what was the intent of the question.
Yeah.
What I did, there is already a lot of data exists in your literature, the literature that comes with the medicine and
Yes.
elsewhere also. But ultimate user will not get all the data, and even if the ultimate user is getting it, he is not able to comprehend that data what you are providing. So there should be probably there should be a way by which you can percolate that data down to the consumer level. And I know that many medical representatives and all, they go to the doctors, and I don't know how much they talk about the medicine and its contraindications or whatever, the adverse reactions and all that. But there should be a proper mechanism for that. And only pharmacovigilance would truly be effective, I guess so.
Yes. Even in countries like US, medical representatives generally report adverse events. And as you mentioned, how it goes into the normal population, I will just give an example and conclude the session. For the example, drug apaxipam, which is basically used as a drug thinner, right? So this drug has an additional risk minimization plan. Like we have to distribute a patient alert card to the patients of European patients, right? In India also we use apaxipam, but here doctor tells if you get any surgery done, so before that just inform us that you are on apaxipam, we will stop this medication. But there they carry that patient alert card. It is a part of the risk minimization tool. So they have to carry and show to the doctor, I am on apaxipam, and then they will take the necessary measures accordingly. So some drugs are associated with this patient alert cards, educational programs are run by pharmaceutical companies to educate physicians and patients. So these are all additional risk minimization measures. So these are all associated with pharmacovigilance ultimately.
Thank you. I request my colleague, Dr. Krishna, to weigh in.
Thank you.
The session was very informative. Okay. You have dealt with introduction of the talk about pharmacovigilance and clinical stages and post-marketing safety and key technologies and revolution in the pharmacovigilance and some case studies. Directly. Okay. It was a very nice, informative session. Thank you.
We have a question for you here. So, speaking about patient safety, some drugs have been already banned in some other countries, but still being used in India. Why we can't ban such drugs? Like, for example, Nucleotide, but people in India are still using it as required. When they are having headache, they use it frequently.
Yeah.
How can you work on this kind of
Yeah,
situation?
I'm coming to that. So basically, it's a good question that I also had. So majorly, as I mentioned to sir, that the lack of pharmacovigilance is one thing. Lack of reporting of adverse events. How these regulators come to know? When we voluntarily report, right? Spontaneous reporting is, we get almost 80% of the cases from spontaneous reporting. Spontaneous reporting is where voluntarily the people will report adverse event, right? So from that data, we basically assess that it has a risk associated with Indian population, right? If there is no clear data, authorities will have, then they could able to prove, the pharma company could able to prove that there is no risk associated with Indian population. So basically the people in the US are genetically kind of, genetically they are different, right? So they are Caucasians, we are Asians. So in Asian populations, we have different genetics. So genetically it might not be impacting us. Some drugs are like that, some diseases are also like that. You can see some, I was working on one of the rare drug which is used like called as infliximab, Solaris, which is used for PNH, peroximal nocturnal hemoglobinuria. The drug, one shot of the drug, it is taken for one weekly basis. It will cost around 5 lakhs one shot. And the patient once had PNH, he has to be on that medication continuously for years together. And it becomes impossible, right? In India, we don't have that. Fortunately, that disease also don't exist in India, right? We are not genetically prone to that particular disease. That's how they justify. But there are many publications, even CDSO puts recalls the drug information and everything. But later on, there might not be sufficient data, or pharmaceutical company will be asked to prove that that drug is safer. So if they are able to prove that that drug is safer for the Indian population, then that drug might not be banned in India. So that's what I told the regulations. There is no harmonization in the regulations. So it changes back on country-wise country. Right? Thank you.
Thank you, sir, for imparting your profound knowledge and enlightening words. I would also like to thank Dr. Sarimullah Khan and Dr. Krishnanand Kamath for being here for the plenary session. I request Dr. A.R. Shabaraya, sir, to present a memento and certificate to Dr. Vijay Kamath. Sir.
I'm not a doctor, I really am from.
I request Dr. A.R. Shabaraya, sir, to present a memento to Dr. Sarimullah Khan and Dr. Krishnanand Kamath. Thank you.
Bangalore is known as an education hub. Many students from different places come to Bangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. Raghavendra Rao. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. Raghavendra Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Bangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental,
Co-founder of InfoCard India Private Limited, who is a pioneering software engineer with a remarkable journey spanning over 15 years in the technology industry. Her career has been defined by a deep-seated passion for innovation, a commitment to excellence, and a relentless drive to leverage technology for the betterment of education and research. Her team's products demonstrate a dedication to innovative, impactful solutions in the field. Over to you, ma'am. I hope my screen is visible.
Yes, ma'am, it's visible.
Yeah. So this is my farm, which is animal simulated software in pharmacology. This is completely cloud-based technology. All the experiments are there, whatever you have in pharmacology, all the experiments are there. This is about us. We have veterans from pharmacology industry, Dr. Jiya Patil, Dr. Swami. Everybody knows them. What exactly happened? It started in late 1980. This product started in 1980 with the name of X-Farm. Then it was acquired by IPCTPS, and now it is with us with the name of MyCare. These are the few basic features. These are the few images from our portrait. How the experiment will look like. You can see here. A few basic images I'm just showing you here. This is a dog PPHR. These are few other graph experiments. I'm just logging into the software. I will be showing you what exactly the features you will be getting. Small login is there. This is the dashboard of it, how the things will look like, how many experiments are there until now, how many experiments have been closed, how many, what is actually the percentage, who has logged in into the software, what all recent pages were there, how many experiments have been performed, what the number of experiments performed till now. Let me show you the tutorial on how the experiments we have. We see the list of the experiments. I hope it has been clearly visible. List of the experiments which you have. If you have it, it's 14. We have the X-Farm rapid bioresource system spectrograph, CCD, molecular isophagous effect of drug on dog with BP and HR, BP heart rate, effect of drug on dog heart. Then we have the bioresource instruments from RAJIV, HA. These are the few basic experiments. Then we have in the ecology, we have dose response curve. These are all the experiments for the dose response curve, 5 experiments for that. For PA2, PB2, these are the list of the experiments which we have. Not showing you, please you can just see animal speak all the experiment. This you can see here for PB2. Then the biosis experiments are, you can see the list of the biosis experiment, biosis, serotonin, oxytocin, ADR, metropin, ATH. Liquid acid, 4.6. Anti-allergic activity of mast cells. Then we have experiment of the whole animal locometer. We have elevated dust base. We have electroconvulsometer. We have rotor rod, tail gate, eddy sort, biologic testing, shy, thyroid, all these things. I'm not taking all the experiments right now, just the basic one. I'm just taking just to show you how the things work. Let's start. I'm just very common experiments. PPHR showing you. Will not be taking the complete experiment, just to show you how the full experiment looks like. Pharmaceutical experiment and because this main concepts and the time we don't have much time for this. This is the introduction part. This is the objective of it. These are the equipments. Going on fast. is taking 100 epithelial time. This is the range dose to be calculated to mg by kg. Recommended dose range has been shown in one. We technical graph, what is actually needed in the C. This is it. In the frame, we can see a BP goes up and then it again comes down below than the normal. And after some time, it just gets normal again. Same with the HR will shoot up, kind of somewhat down, then it will again shoot up, and then after some time, it will down. Then let me take a set of, let's say, every minute. I'm injecting 200 mg by kg, which is the recommended dose. BP and HR both will shoot up, and BP will just go to the highest point, which is around 200. Scale is to measure BP and HR both. This is for every grade. Adding another set of epiphil, say injecting again with then it is already there in the body, so total comes out 400. BP and HR will shoot up at a specific rate. This is the list of the blockers, if it is there in the body of the dog. And going to the observation part now. This is what exactly we have done up to now. Looking at the student has to write it here, not at the next time we have to, then we have taken every what was the mean BPHR randomly. I am just taking any remarks which is there, we will just write the remarks for you. These are the set of the MCQs which has to be performed by every student. 10 questions are there. Right now I am just taking it randomly as 8. Not telling you what exactly it is. You can just see it here. The correct answers for all these MCQs will be completed. Then we have a list of question and answer which will be there for every experiment. What does blood pressure, high blood pressure increase in thyroid arteries are concluded? The students are meant to write every answer to every question. We have a set of action of ACIs. One said why, how the system reduces BP, why physiology reduces BP. So all these questions are meant for students to answer. Set of 15 questions are there. We have to submit them, we have to write the chair. And whatever has been done by the students, you just have to share it. Everything will become a part of the PDF. PDF is generated for every experiment. You can see here our logo, your institute logo will be there, name of the students, their hall ticket number, email ID is there, experiment name is there. What all we have done will become a part of this report. The draft made, what have we done, which all got there. Then there will be a list of the MCQs. Correct or wrong, it will be mentioned here. Either the correct answer will also be there. Then we have the list of the written questions. Whatever they have answered, it will be there. This was one experiment. growth response curve of system immunity. This is the setup. Transducer definitions
A
are
student
there.
physiograph and digital data acquisition system are used for recording of biological responses from isolated tissues and whole elements. In clinical setup, they are used, these data acquisition systems in association with transducers, calibration of physiograph digital data acquisition system called CAD. The transducer is connected to an interface which helps in reduction. Transducer converts a mechanical signal, change in length or change in the force of contraction, generated by isometric transducers. Force transducers are used to record the isometric contract. Isotonic transducers are used to record the isotonic contractions. Open bar outer jacket. It is generally made of perspex or glass.
Definitions
It
are
holds
there.
that water warm thermostatically. At 30, reservoir IV reservoir has an arrangement to deliver the physiological solution at a fixed rate and with constant pressure drop. Ernest Torpedo, 1872 to 1950. Eminent French scientist who prepared some of the first and Alfred Joseph Clark, 1885 to 1941, distinguished investigator in.
I'm just moving it. These are the list of the scientists who have worked on this study. Alfred Joseph Clark, their description, what exactly they have done, their actually here. Philosophy is there with the list of all the definitions, whatever terms are there in mentioned. Quiz is there, where you will be getting a set of 10 institutes, which is students have to perform. They have to give the correct answer. Right now, I'm just doing it. Taking it as A, but the student has to perform it. Then this is a list of the written question and answer, which will be accompanied by three experiments. Not taking the complete part, just to show you how much is that is there. These are the videos which we have in our experiment. All these videos were being recorded when we have actually performed this experiment. You can see the actual dissection part, what was performed.
For isolation of ileum, first identify the pair scotch, the ilocecal junction. Exclude the terminal 10 centimeters of ileum. Cut the ileum into pieces of 2 to 4 cm length and maintain them in warm Tyrol solution at 37 degrees Celsius with aeration.
Here's batch. This is the ilocecal junction. Everything has been defined here and shown to our students. Ileum, which will be cutting it and then mounting it also. I'm just taking the paper, I'm going to the next.
Take a piece of ileum in the Petri plate containing aerated and warm Tyrol solution. Cut the mesenteric attachments. Clean the lumen of this tissue by passing warm Tyrol solution through its lumen. Care is taken not to expose the tissue to very high distortion which can affect the sensitivity of the tissue to drug substances. Generally, the tissue is washed by taking a pipette of 10 milliliters capacity and warm Tyrol solution is used for washing. Tie one end of the tissue to the aeration tube. Hold the thread of free end along with the aeration tube. Tie one end of the tissue to the aeration tube. Hold the thread of free end along with the aeration tube. Transfer in this whole process, the tissue is never stretched or disturbed. The aeration tube along with the tissue to the organ tube containing warm Tyrol solution. In this whole process, the tissue is never concerned. The process of sacrificing the process of studying and examinations should start with the minimum possible dose. RAJIV,
Not taking the complete experiment, not showing you what will happen with this. See here,
click baseline button to record the baseline reading. Click the test tube containing one inject button to add the histamine to the tissue bar.
the responses will be recorded in the laptop screen below.
Click watch to watch the tissue in the open tube.
The two responses I will be showing you, not the complete experiment. These are the responses which we have in this record, these responses. Then you can see in the table it will be automatically generated with the concentration of histamine amount added to the organ bar, concentration in the organ bar, micromolar concentration in the organ bar, molar concentration, log of concentration. All these things will be recorded automatically. Only the responses will be written. You just have to see the responses here, note it, and then you just have to write it here. What is actually the response? You just have to write it. Not doing the complete part now. So here I am just telling you that I am not doing the complete experiment here. Right now, in the tutorial mode, all the experiments are open. You can just make your login. This is the contact form here. You can just go to the contact form, write your name, your email ID, and your institute name. You can just contact us, and we can make your login where all the experiments you will be able to perform tutorial mode. You will be able to see here also giving 1 year updations. Right now you can see 2 experimental log. They are under the updation process as in the testing process. As and when the testing of these 2 experiments will be completed, even those will be shared to you and uploaded here. So these also right now, when it has been launched, it was around 31 experiments. Now we are having 38 experiments with the tutorial and the exam mode. You can see in the exam mode, we are having all the examination of all these experiments. You can see the rabbit eye experiment, 2 exams are there. Dog PHR experiment, 3 exams are there. So all the examinations are also there for all the experiments. And in the practice mode, you can see that all the exam mode are also open. These are the practice exam mode which the student can perform anytime. Then we have the scheduled exam mode, which the faculty will be having the access to it, and the student can give the final exam. Whenever there is a final exam for the student, the faculty will be having the access to schedule the exam. So on that particular date and time, the faculty can assign the exam for the students. And on that particular date, the student will be able to conduct that exam. Whatever the student will be conducting the exam, the report will go directly to the faculty, not to the student. The faculty can give marks, remarks, or both. Let me show you one practice exam also for let's say rabbit eye. This is the examination mode of it. Since it contains so many animation, it takes some time to load it. This is the effect of rabbit eye examination part, not the tutorial part. Once the tutorial part is complete, only then we expect the student to perform the examination part. This is the setup for rabbit testing. These are the options of drugs which we have. I am not showing you the theory part of it directly, which is going to be examination part of it. It's a unknown one. We are taking the right eye. I hope here many people who might have used these experiments within their own login. This will be what will happen after adding drugs. In the left eye, I am adding unknown food. The effect can be seen here, not exactly the effect of unknown food here. These are the focus which we have. You can see the effect of torch here. Torch effect is there in both of them. You can see the full effect is not there in the left eye. In the right eye it is there. So we got to know what exactly what is there. This is the scale. You can just measure the scale. You can just measure the eye whether it has been dilated or not. From here we can just measure. This is the tonometer reading 20 is right now, and here is 14.8. So whatever is going to be doing in the observation part, in this right here, the right eye on 1, left eye on 2. From here they have proved what is actually on 1. They can just write the ocular IP tension, how much it was before and after, and what is good before light effect was present and in unknown food it was active. So whatever the effect is there, the student has to write it between side before, after, and then this is what. So here they have exactly what exactly is the unknown one drug and unknown food. Okay, here unknown one is very small, unknown food is comparatively larger. Let's say below carbine. Another set of answer the question for in the examination board is to be getting the file written question answers which the student has to perform, and the report will be drawn to the student to the faculty directly. Student will not be having the access to this report. The result we can see it here. Whatever the result was there, we will see we will be able to see it here. This is the report part. As the report is made, it will go to the faculty directly. This was the examination part. This is the practice exam. You can see both the answers are wrong. Only 2 they are selected, 3 has not been done, and both of them are wrong. The written question and answers has not been effective. This is the log of the event, what has been done when. This is the observation taking which has been created by the students. So this was the examination part of it. These are the reports, how the report will look like for the faculty. How they will be able to see the report. Like this is the Shahid schedule report the student has to perform. Thyroid revisions. So the faculty will be having the access to all the reports what the student has done. I think I'm taking a lot of time instead of lunch time. So I'm just let me show you another report. This is for the bioessay. This is bioessay report. Every experiment we can see the reports are there. Period is being generated for every experiment. A list of the experiments you can see what we have here. So that form is already there. This is what we discussed. So that. Thank you so much for giving us some time for demonstrating myself and Ms. Srinivas software here. This is the feedback section. If there any kind of feedback, even after the children, if you are giving any suggestion of some experiment is not working or something has to be there, something is missing, you can just write in your feedback and if possible, we will be incorporating that particular suggestion in our software. This is myself. These are the two things provided. Users, list of the experiments are there. So, any doubts, any questions you have, you will ask me now or you will fill up the form and you will contacting you further. So, thank you so much guys for sparing your time.
If anyone has any doubts or clarification, please raise your hands. Thank you, ma'am, for your insightful demonstration.
This is again.
You have selected the experiment. VALACHIL.
Thank you, ma'am. This is the end of session 3. We have now come to the end of scientific session and we will begin with the valedictory ceremony at sharply at 2 p.m. While active, please do have your lunch and come to the auditorium 2 p.m. for the valedictory function. Thank you, everyone.
Bangalore is known as an education hub. Many students from different places come to Bangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. Raghavendra Rao. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C. A. Raghavendra Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Bangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities, and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security, and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super specialty hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Pandeshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the VALACHIL campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas group of colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom, and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Bangalore. 5 departments have been recognized as research centers by VTU to pursue PhD and MSc. The institute has well-qualified, committed and motivated faculty. Bangalore is known as an education hub. Many students from different places come to Bangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. Raghavendra Rao. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C. A. Raghavendra Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Bangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities, and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG, and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangaluru. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security, and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is the 700-bedded super specialty hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, The college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experience students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Pandeshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both under, postgraduate, diploma and doctoral courses in pharmacy. The college is located at the VALACHIL campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, Architecture Studio, Exhibition Space, Climatology Lab, Material Museum, Survey Lab, Model Making Studio, Specialized Classroom, and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Bangalore. 5 departments have been recognized as research centers by VTU to pursue PhD and MSc. The institute has well-qualified, committed and motivated faculty. Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. Raghavendra Rao. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. Raghavendra Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities, and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG, and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, The college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experience students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Parneshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the VALACHIL campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom, and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Bangalore. 5 departments have been recognized as research centers by VTU to pursue PhD and MSc. The institute has well-qualified, committed and motivated faculty. Bangalore is known as an education hub. Many students from different places come to Bangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas Group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. Raghavendra Rao. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C. A. Raghavendra Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education.
Coming together is a beginning. Keeping together is progress. Working together is success. A very good afternoon to everyone present here, distinguished dignitaries, invited guests, staff and all the students. I, Jocelyn Dias,
And I, Jessica Fernandez,
on 6th Farm D, on behalf of Srinivas College of Pharmacy, Vaikunta VALACHIL, Bangalore, and Indian Pharmaceutical Association, Local Branch, Bangalore, are delighted to offer a gracious welcome to all of you for this voluntary function of 7th National Conference on Innovative Practices in Clinical Training and Patient Safety. I request Dr. Vinesh K. Chandal, Professor and Head of Department of Pharmacy Practice at Srinivas College of Pharmacy, coordinator of today's function, to escort the dignitaries onto the dais and join them.
it is our culture to remember God Almighty before everything we do or start. So let us begin this function by seeking the blessing and presence of the Almighty. I would like to invite Ranjita and Gauri to lead the prayer, and I request everyone to rise for the same. Thank you, Ranjita and Gauri.
I request Dr. E.V.S. Subramanian, Head of Department, Pharmaceutical Chemistry and Vice President, IP Local Branch, Bangalore, to introduce and welcome our dignitaries to the gallery.
Now, we have reached the last part of the 2 days national conference, that is innovative practices in clinical training and patient safety. On this occasion, I take this opportunity to invite you all to this program, VALACHIL program. I take pleasure in introducing the guests present on the dais for this program. I cordially invite Dr. David Rosario, Medical Superintendent, Srinivas Hospital, Mukka, Surathkal, as the chief guest of the today's program, VALACHIL program. Dr. Rosario, he has completed his MBBS degree from AJ Institute of Medical Sciences and Research Center, followed by MS in ENT from the Father Mullers Medical College. He has more than a decade of experience in the medical field. He served in various capacities, both at the clinical as well as administrative services. And he is also experienced in patient care, hospital management. Throughout his career, he has been actively involved in medical education, mentoring young professionals, contributing to the development of healthcare standards. His leadership as Medical Superintendent of Srinivas Institute of Medical Sciences and Research Center, Mukka, has played a key role in enhancing institutional efficiency and promoting a culture of excellence. We are truly privileged to have such a highly experienced and dedicated professional with us today. I welcome you, sir, to this function. I take this opportunity to welcome Madam Anita Sikwera, guest of honor of today's program. Madam has completed MBBS in MD in internal medicine from Father Mullers Medical College, Mangalore. She has more than 10 years of experience in the field of medicine, had special interest in treating diabetes, hypertension, cardiovascular diseases, respiratory diseases, snake bite management, critical care medicine, and strokes, etc. She has numerous publications in national and international journals to her credit. Presently, she is working as Professor of Medicine, Srinivas Institute of Medical Sciences and Research Center, Mukka, Mangalore. Madam, I welcome you to this program. Incidentally, we are also fortunate to have the presence of Dr. Chandrasekhar B.M., Professor and Head, Department of Pharmacology, HSK College of Pharmacy, Bangalore. He happens to be the chairperson of VOS in Pharmacy, PharmD program, RAJIV University, Science Bangalore. I welcome you. Our main source of inspiration, support, encouragement, Dr. A.R. Shabaraya, Principal and Director, Srinivas College of Pharmacy. He is the convener of the program. He has anchored completely all the activities, guided us for a successful organization, planning, execution, and completing of this national conference. I welcome you to this program. I also welcome my colleagues, Dr. Krishnan Kamal, Professor of Pharmaceutics, and Professor Dr. V.H. Chandu, Professor of Pharmaceutics, to this program. I also welcome my all other colleagues, all the delegates who have come from all over from far off places. They are who are accompanied by staff members and MCs and all other JT panels, everybody who have contributed immensely for the successful organization of this 2 days national conference. I welcome you all. I hope you will enjoy this program. Thank you very much.
Thank you, sir, for your brief introduction and warm welcome. I extend a warm welcome to you, sir.
Happiness radiates like a fragrance from a flower and draws all the good towards you. Now it's time to florally welcome the dignitaries on the dais. I request Dr. A.R. Shabaraya, Principal and Director of SCT, and and President, IPA Local Branch, Bangalore, to welcome Dr. David Rosario, Medical Superintendent, Srinivas Hospital, Institute of Medical Science and Research Center, Mukka, Sir, with a bouquet of flowers. Thank you, sir. I request Ms. Arunanjali of 6th Family to welcome Dr. A.R. Shabaraya, Principal and Director, Srinivas College of Pharmacy and President, IPA Local Branch, Bangalore, with a bouquet of flowers. I request Ms. Kaveshri of 6th Family to welcome Dr. Anita Sikwera, Professor and Head of Department of Medicine, Srinivas Institute of Medical Sciences and Research Center, Mukka, with a bouquet of flowers. I request Ms. Minchu of 6th Family to welcome Dr. Chandrasekhar VM, Professor and Head of Department, Pharmacology and Toxicology, HSCCP, Bagalkot, Chairman, BOS, Family, RGUHS. I request Mr. Oliver Steve Pinto of 6th Family to welcome Dr. E.V.S. Subramanian, Professor, Vice President, Indian Pharmaceutical Association, Local Branch of Bangalore, with a bouquet of flowers. I request Ms. Sulalat of 6th Family to welcome Dr. Viresh K. Chandra, Professor, Head of Department of Pharmacy Practices at Srinivas College of Pharmacy, with a bouquet of flowers. I now request Ms. Nishnita D.K. of 6th Family to welcome Dr. Krishnananda Kamal Sir, Professor, Department, Pharmaceutics, Srinivas College of Pharmacy, with a bouquet of flowers. I request Ms. Arunanjali to welcome Dr. Subhashri, Professor of HOD, Pharmacy Practice, Swami Vivekananda College, Pharmacy. And I also request Arunanjali to welcome Ms. Vijaya Shri, Associate Professor, KV College of Pharmacy, Gadag. Thank you.
We are delighted to have with us Dr. David Rosario, Medical Superintendent, Srinivas Hospital, Mukka, Sir has the Honorable Chief Guest of today's valedictory ceremony. I invite Sir to speak few words.
Dignitaries on the dais, dignitaries of the dais, all the delegates of this national conference, and my dear colleagues and students. First and foremost, I would like to congratulate Dr. Shabraya and his entire team for organizing this wonderful national conference. Indeed, they deserve a big round of applause. I believe this is the 7th successive year that they are conducting this conference, and it's really appreciable. I believe this, why I'm saying it's a successful conference because from what I gathered, there have been about 500 delegates who have registered for this conference, about 250 paper presentations which have happened in the span of 2 days, and about more than around 50 oral presentations in a span of 2 days. Really appreciable. It's a wonderful academic fiesta, and definitely it's a very successful conference, I should say, and I congratulate Dr. Chandra and the entire team for putting all the efforts for this. I mean, that shows the dedication Dr. Chandra and his team are that they are shown towards the academics and in promoting the College of Pharmacy. I think there are representations from about 5 states, and so saying around 30 universities, delegates from 30 universities also have participated. It's really appreciable. For a small city like Bangalore, in a small campus like VALACHIL, such a huge representation that puts our college and the university at the national level. So really it's appreciable, and I thank all the delegates who have volunteered and attended this conference and making this conference a successful one. coming to the conference, the medical field, as we know, is an ever-evolving field. Day to day, new and new concepts come, new and new technologies develop, and when it comes to pharmacology, with newer drugs come each and every day, and the newer drug delivery systems and the newer techniques all are cropping up each and every day. And this conference gives us an opportunity to learn newer things, to understand the newer concepts, and enhance our knowledge in a small city. Otherwise, to learn each and everything, we can't go to different places. But this conference provides an opportunity for all of you to understand and make be abreast with the newer concepts and newer knowledge. The College of Pharmacy indeed has been performing extremely well. It's of course, it's a part of the RAJIV University of Health Sciences, affiliated to RAJIV University of Health Sciences, and the results have been excellent over the years. And all credit goes to the faculty who are extremely hardworking and dedicated. I mean, of course, they deserve a round of applause. I mean, personally, I've seen, there are the students as well as the interns from the College of Pharmacy and the faculty from the College of Pharmacy are posted in a hospital. And the dedication that they show, it's really commendable. I believe Dr. Anita Sikara will agree with me, because most of the pharmacy students are posted in the Department of Medicine, and I would say they are on par and sometimes perform even better than our MBBS interns. Such is the quality of the students of our So I will not take much of the time. Once again, I would like to congratulate Dr. Shabraya and his entire team for organizing this conference. And Dr. Shabraya, of course, he's been very close to us. I've been knowing him for almost past 10 years from the time I joined this organization. And when he invited today, of course, there were other commitments. I said, no, when Shabraya sir has called, definitely we have to attend. Anita Sikara, by the way, she is my wife. And it also happens to be that today is my wife's husband's birthday. So it's my birthday today. So it's a joint occasion for me to be part of this wonderful event. And I thank Dr. Shabraya for inviting us on this day. And congratulate the entire team for organizing such a wonderful event. And I'm sure all the delegates who have participated in this have benefited a lot from this conference. And I'm sure you will take the name of our Srinivas College of Pharmacy wherever you go, and remember this event, and also help us to propagate this institution. So thank you one and all, and have a wonderful evening.
Thank you, sir, for your great words of wisdom. I now request Dr. Anita Sikara, Professor and Head of Department of Medicine, Srinivas Institute of Medical Sciences and Research Center, Mumbai, to address the gathering.
Good afternoon, everyone. Dignitaries on the dais, Chief Guest Dr. David Rosario, the Principal of College of Pharmacy, Dr. Shabraya sir, and other dignitaries on the dais, all the faculty members, interns, and all the delegates of different colleges, different universities all over India. I should say I am glad to stand before you, and also want to thank Dr. Shabraya and this entire team for inviting me as the guest of honor today. First and foremost, I would like to congratulate Dr. Shabraya and his wonderful team, not only the faculty members, all the interns, all the people who are responsible for organizing such a wonderful event in a short span of time. Arranging a national conference, according to me, it's a very big burden. It's not that easy. From day one to till today, it's a big burden on the shoulders. And you have organized in such a wonderful way. I just went through the brochure. I saw it's very nicely organized, very good talks. Even the pre-conference workshop, I think it was organized online. And I can see we have delegates all over India from different states, and they are eagerly waiting to receive their prizes. And before, I would like to share a few of my experiences. I must say we have
few of the staff posted in our medical college hospital, as well as we found the interns. They are doing a wonderful job. As Dr. David says, in fact, they are doing better than most of the time. I feel they're doing better than our interns and postgraduates sometimes. I would like to thank them also for taking care of our patients, especially when patients have certain adverse drug reactions, all those things. And just organizing one conference is not enough. All of you should keep organizing such small CMEs and organizations. I think Dr. Shabrai is one of the leaders, and he's always guiding all the staff and the students, encouraging them to organize small events, CMEs. I can always see. It could be a word, HIV Day or World Diabetes Day, all the interns come forward, they will organize small event in the hospital. And most of the time, they don't miss even a single national programs and international programs. I congratulate all of you, and you should attend more conferences and CMEs so that you gain more knowledge. As you all know, we are in the field of medicine, maybe pharmacy or medicine. Every day new drugs come, new trials are happening. You can also be a part of the trials, and there are many antibiotics and anti-cancer drugs which are coming. You can contribute. It's not that you have such a good, wonderful teachers, faculty members. You can contribute yourself. You can see how it works, because I can give you a small example. Earlier we used to use sitagliptin, then many gliptins came. But when we went back, sitagliptin was much better than other gliptins. That is one example, because each drug works in a different way. Even the newer drugs come, it doesn't mean that the older drugs are not that effective. You can prove that based on our patients. That's what I say. You can make a combination of the drugs. For example, we have now sitagliptin with dapagliflozin, which is working very well. You can do some researches like that on our patients. Come forward, present papers in many national conference, and take your college, Srinivas College of Pharmacy, to greater heights. Maybe can be national level or international level too. Again, completing my words, I congratulate again Dr. Shabrai and his wonderful team of faculty members and the students. Thank you very much.
Thank you, ma'am, for your inspiring words. Now I request Dr. Chandrasekhar BM, Professor and Head of Department of Pharmacology and Toxicology, HSKCP Bhagalpur, Chairman BOS Foundry, RGUHS, to speak a few words.
Good afternoon to everyone. It's a great pleasure here in this national conference. I think every year you are participating since from 5 years. My college students are participating in these conferences. And students from this Srinivas College will also participate wherever we will conduct the conference. It's a great exchange on conferences and knowledges and everything. So this conducting a national conferences day to day, it's a very important, and it's in a continuous program they are conducting since from 7 years. So I congratulate Dr. Shabrai sir and whole college team for successful conduct of these conferences. As I US Chairman for Foundry, you are bringing some of the changes in universities with suggestions like with Shabrai sir and all principals. Some of the fellowship programs in universities like fellowship in oncology, fellowships in pediatrics. Maybe you are pushing that 1 year, 1.5 year fellowship after completion of your Foundry programs. This is a effort is going on. Maybe future we will have a specializations in particularly oncology, pediatric and geriatric. So that might be chances from RAJIV GANDHI will be for your pharmacology peoples and for Foundry students. And this is an era in which the world is growing very fast, where knowledge is not only sufficient, you have to be successful, where you have to be added skills. So last week I am there in the Naipur Guwahati. I am being a good one example for that. A Foundry student who has developed a very good technique, which is to identify breast cancers in rural area with a small iPhone with IT people. There's a collaboration with IT and the Foundry student. instruments, and his technology was transferred to USA, and it's a good example for entrepreneurship. Now, I give an example. For example, if you say that, I will ask you, when you put money and a banana in front of a monkey, what it will choose? It will choose a banana, right? Because money can bring a lot of bananas, but it doesn't know that. Like in front of you, if you put that after completion of your degree, whether you go for salary related jobs or you want to be entrepreneur. Entrepreneurship will bring a lot of money, and you can able to give a jobs, and you can create a wonderful works. So that's the era you have to be change your mindset that you have to do your own companies and all with IT people. A lot of data, patient data, pharmacovigilance data, which is evolving day by day. Healthcare and health, digital health, which is an upcoming field where the pharmacy students and pharmacology people can do wonders if you join with hand with an IT people. So you can, in this way, you can able to think in future, definitely you can make not only money, your name also, and bring a lot of patient safety aspects in these countries, even through globally also. So this is a message from traditional job, from salary to entrepreneurship is an era where startups and all government of India is funding. You can do a lot of wonders. So lastly, I would want to say that a bird will give a birth to babies. After some days, the small baby will ask to the mother, what should I do? Mother says, wings belongs to you, sky is not limited, you can fly whatever the height. So in this way, I will say that once you complete your Pharm D or postgraduate, whatever it is, you have a knowledge and develop your skills, you can do wonderful. So with these few words, I can conclude my speech. Thank you.
Thank you, sir. A pessimist complains about the wealth, an optimist tries to change it, and a leader adjusts the sails. The sails for this particular notion were adjusted by a person who is not only a great motivation to all of us, but a visionary, and the person who gave us the belief to bring together this event. He is none other than our beloved principal. I invite our Honorable Principal, Dr. A.R. Shabaraya, President IPA, Bangalore, to address the gathering. Before that, may I now kindly request all the participants to take a few moments to share your valuable feedback on today's conference. Your suggestions and opinions are very important to us and will help us to improve future events.
Good afternoon, everyone. I'm Nafa from 4th Pharmacy, studying here itself in Srinivas College of Pharmacy. So I'm very happy to be standing here to share my experience of this conference that our seniors, put together. So overall, it was a very vibrant and very enriching experience. We had a lot of opportunities and a lot of exposure. We participated in poster presentations, quiz, and designing the patient information leaflet also. So personally, I think poster presentation helped us, bring out our ideas in a very impactful manner, and Phil helped us design in a way that everything is, patient friendly, that the way we can explain it to them better. And the quiz was also very fun and a very, very enriching experience. And also the sessions, I couldn't attend a lot of sessions because we were busy with the poster and the quiz and all. But the ones that I attended, I think they were very yeah, they were very impactful and they were all based on current trends and future scope. So they helped us a lot. And also the food was also very appetizing. And yeah, and thank you to the whole organizing committee for putting such a nice program. And yeah, overall it was very fun. Thank you.
Very good session. Don't you all agree? Yes. Yeah, few topics were beyond our level. To be true, sir. But yes, how much it was presented and how much it was capability of each student is different. So according to me, it was really, really interesting, especially the today's topic, the pharmacovigilance. Very interesting. And in future, we should also try, attending more sessions like this. Though it was very boring in between, yet we all really enjoyed, right? I can't hear. Yes. Yes. Thank you, Srinivas, College of Pharmacy, principal and whole staff and whole team members. Really, your hard work, we can't understand, but really a very good, what do you say? Very good effort to make a lot of students get engaged in sessions like this. I thank everyone wholeheartedly and thank you so much.
Would anybody else like to give their feedback?
It was really a nice experience here, and it was my first time presenting a poster here, and also we collected a lot of ideas to do it in our college as well. And the food here is also really nice. We got to explore manual foods here, and overall it was a nice experience, and thank you. And the staffs and students here were really friendly, so thank you.
Thank you, dear delegates, for your wonderful feedback. Now, we move on to presidential address. Therefore, I request our Honorable Principal Dr. A.R. Shaharaya, President, IPA, Bangalore, to address the gathering.
My good friend, today's chief guest, Dr. David, Medical Superintendent, Srinivas Institute of Medical Sciences and Srinivas Hospital, Dr. Anita Seguera, Professor, Department of Medicine, and Dr. Chandrasekhar, Chairman, Board of Studies, PharmD, RAJIV University of Health Sciences, all my professional friends, colleagues, and dear students. You might have heard from Dr. David. Yes, everyone is appreciating Dr. Shaharaya, right? But I can give only the idea. I can provide only the platform. But the success comes from performance that is done by our students and from audience. Because I want to tell something here. Yesterday, the resource persons came from different institutions, and we identified the evaluators from various institutions, various pharmacy colleges, everyone was appreciating the posters, the title selected, and the confidence of the students, how they are presenting what is the content. Because it was might have done, suggested by teachers or guides, but the confidence, it comes to the student when they are thorough with the topic. And all the evaluators, they are appreciating the presentation style and the new topics, about 250 topics are given for the poster presentations from different colleges. Everyone is saying that yes, how these people got these new novel topics. For you, it is a exchange program, came from different areas, and we can go through the topics where we can extend our work. So that is one way it is good, and even seeing that they posted oral presentation, confidently that how they are presenting it. Because we know the contents, presenting in front of the evaluators, that skill development, what is required. When you are going for the interview, many times even if you know the contents, we are lagging behind the presentation style. The skill development, there is major requirement. If we are participating more and more conferences or giving more and more seminars, yeah, definitely the skill confidence will build up. That is the plus point from attending this type of conferences. This is not only scientific. You might have seen that some more competitions are given here. Pharma quiz, what I mentioned here, and pill. Yes, one side, collecting the information and how to prepare the pill. There is major requirement, especially for drug information services or pharmacy students, especially here. Because I have seen more than 80% here, pharmacy students are here participating in this. Yes, all the topics are also very good on the suits for them. But there is a drawback in RAJIV University now. University exams are there, the students are facing, so they could not focus much here. So those who have taken the initiation in the preparation of pills and the pharma quiz, yes, you forget about the prices. What you have gained here, that is your success, that is the prize for you. The sweet memories for 2 days what you had here. Interacting, developing the contacts with the research persons, or interacting with so many students from different colleges, different states. We have 5 states students are here, and 13 universities, what I said, and 27 colleges. Each student will have their own idea, or their culture may be different, but when they are joined together, we can go for the exchange of the culture, system, skills, ideas. So that is the plus point what we gained here. And we started with a small number 7 years back, but every year numbers keep on increasing. There is a sign, the students, those who come here, they are giving very good feedback, the benefit they are expressing for their juniors, and every year, even this year, we gave this very short time. Just 1 month, not even 1 month, within short time, we have started this level initiation. Even though the response was excellent, so I appreciate all the participants. Prizes are immaterial. Here, your participation, that is the achievement what you are gaining here. So, even in future, attend more and more conferences like this, either in Bangalore or any other state. Because we have some of the evaluators from Tamil Nadu or even other states. They will judge that what is the quality of the students in different areas. Easily they can get ideas there. So when they are sharing this information, we are learning, our faculties are learning, yes, what best can be done or what we added. That is for the faculty side also a benefit for us. By going through one round, by evaluating or by seeing the topics, each teacher will get few more ideas to go for the exchange of the work. So even so many faculties are participated in that, and I am very happy to share that when the PharmD program is there, related to PharmD, and our PharmD chairman has attended this and chaired the session, and it is a great pleasure for us to take further steps to support this kind of conferences and activities in RAJIV University side also. Yes. And I'm sure that our Dean, MS Medical Superintendent and Dr. Anita Madam always with our interns, they are giving good support when they are going to the hospital. I can initiate, but other side they are given full support to conduct various activities. So even our interns, yes, I want to give a big hand for your interns first, because who has taken wonderful job responsibilities by the departmental people. Within all my faculties, they have taken excellent responsibilities and molded them or directed them, yes, do that. And day and night, they work for the past 15 days. Now they will realize the value of their effort. When all the recipients expressing their views, yes, our interns definitely get satisfied, and it is the motto, the motivation for the immediate juniors, because every year interns are taking the step, initiation for this. We have to do, add some more steps to that. It is the motivation for even for the juniors, and let it go as such even in the future. And I wish you all the best. And this is not the end of the session. This is a small beginning for future communication. Wish you all the best. Thank you.
Thank you, sir.
As a token of gratitude and honor, I now request Principal Dr. A.R. Shabaraya to present a memento and token of love to the chief guest, Dr. David Rosario, and his better half, Dr. Anita Silquera, today's guest of honor.
Yeah, just now I heard that Dr. David is celebrating his birthday today. He is supposed to attend the function in other occasions, but he accepted our invitation and joined with us. Really appreciate for his dedication for pharmacy profession. Thank you.
I also request Principal Dr. A.R. Shabaraya to present a memento to Dr. Chandrasekhar B.M. As a mark of appreciation and respect, I now request Principal Dr. A.R. Shabaraya to give a memento to our chairpersons of yesterday's session, Dr. Subhashini R., Professor and Head of Department of Pharmacy Practice from Vivekananda College of Pharmacy, Tamil Nadu. I also request Dr. A.R. Shabaraya to present a memento to our evaluator, Mrs. Vijayashree, P. Associate Professor, KLE College of Pharmacy, Gadag. Before we proceed further, I would like to take a moment to express our heartfelt gratitude to the sponsors who have extended their generous support in making this conference a grand success. We sincerely thank our sponsors, Camco, SLA Book House, Planet Consultancy, Durga Labs, Styleway and Little Millennium Play School for their valuable contributions and continuous encouragement towards academic and professional development. A special mention to Camco, the Central Arakanat and Coca Marketing and Processing Cooperative Limited, established in 1973 and based in Puttur, Dakshin Kannada. Over the years, Campa has emerged as one of India's leading chocolate manufacturers while supporting Arakanat and cocoa farmers across the region. We are pleased to have Mr. Dinesh, Marketing Executive from Campa with us today. We also showcase the products to a well-researched stall during the last 2 days of our conference. Thank you, sir.
Talent and skills are the crops that are nurtured, groomed, and given all possible opportunities to grow and grow. Now I request Dr. Danya Prabhu, Professor, to announce the names of the winners of various competitions.
A very good afternoon, everyone. We witnessed an incredible participation, talent, and creativity through various events. Each one of you brought your passion, knowledge, and imagination to the forefront. Without further delay, let's begin with the moment we all have been waiting for. It's my pleasure to announce the winners for the 7th IPCTPS Conference 2025. As I call out the names, the winners are requested to kindly come forward and receive your prizes. I now request our chief guest, Dr. David Rosario, to come forward and present prizes to the winners. Poster presentation research. The first prize goes to Apeksha, Srinivas College of Pharmacy, Bangalore. The second prize goes to Bhumika Patil, HSK College of Pharmacy, Bagakote. Second prize is shared by Chaitanya M, Srinivas College of Pharmacy, Bangalore. Third prize is backed by Nishmita K, PA College of Pharmacy, Bangalore. Third prize is shared by Renisha C, Al-Shifa College of Pharmacy, Kerala. Moving forward, poster presentation review. The first prize goes to Geeta, KLE College of Pharmacy, Gadak. Second prize in poster presentation review goes to Mohammad Zayan Ahmad, Srinivas College of Pharmacy, Bangalore. Second prize is also shared by Harita Praveen, Srinivas College of Pharmacy, Bangalore. Harita KD, Srinivas College of Pharmacy, Bangalore. third prize is also shared by Ms. Vilsita Sneha D'Souza, Sri Devi College of Pharmacy, Bangalore. Oral presentation review. The first prize goes to Tanishka Shri and Swami Vivekananda College of Pharmacy, Tamil Nadu. Second prize is backed by Veena Yelaparuli, Srinivas College of Pharmacy, Bangalore. The third prize is shared by two participants, Srinidhi N. Tantri, Srinivas College of Pharmacy, Bangalore, and Nisarga Uday Kumar Dirimat, HSK College of Pharmacy, Kagapur. Thank you, sir. Now I request Dr. Anita Silvera to please come forward and present the prizes to the winners. Overall best poster presentation is won by Ms. Jeshma M., Srinivas College of Pharmacy, Bangalore. Overall best oral presentation is backed by Mr. Sriniket Acharya, Srinivas College of Pharmacy, Bangalore. Quiz competition. The winners are: first place is backed by Fazila, Nafa, Shashank and Suchita from 4th County, Srinivas College of Pharmacy, Bangalore. The second place is backed by D. Sushma, Sai Krishna Shri from Ratnam College of Pharmacy. The third place is backed by Hannah Marie Biju, Ashley George, Sahana and Shana G from Bapuji College of Pharmacy. The winners for patient information lead their contest. The first prize goes to Navneet Krishna P, Srinivas College of Pharmacy, Bangalore. Second place is backed by Manisha T, Swami Vivekananda College of Pharmacy, Tamil Nadu, and is shared by Anupama Shankar, Swami Vivekananda College of Pharmacy, Tamil Nadu. The third prize is backed by Rachana Ravi, HSK College of Pharmacy,
privilege to extend my heartfelt vote of thanks at this conclusion of the insightful and engaged conference of 7th Conference on Innovative Practice in Clinical Training and Patient Safety. On behalf of Srinivas College of Pharmacy, in association with IPA Local Branch Bangalore and RAJIV University of Health Science Bangalore, first and foremost, I would like to thank the Almighty, whose grace this would have not been possible. Also, I would like to extend my heartfelt thanks to our management, whose grace and the platform which has been given for us to perform this conference. Thank you very much. And equally, I would like to thank the convener of today's function, Dr. Ibrahim, and the president of today's function, under whose leadership it was possible for us to tackle all the difficulties which we faced during the conducting of this conference. Thank you very much, sir. I extend my gratitude to the chief guest of today's function, Dr. David Rosario, Medical Superintendent, Srinivas Hospital, Mumbai, Surabaya, for taking our conference and coming over here, facing the chief guest of today's function. Thank you very much. Now, on behalf of all of us, I would like to wish a very happy birthday to you.